So, hi friends, I'm Dr. Anshul Bansal joining you on this Unacademy platform. As you all know, in today's session, we'll be having the marathon discussion of orthopedics. इस साल के NEET PG एग्जामिनेशन के लिए I am having a marathon session जिसमें अपन टू सेशंस में एंटायर ऑर्थोपेडिक्स कवर करेंगे. टुडे इज द पार्ट 1. सेकंड इसका जो पार्ट 2 है दैट इज ऑन द स्पेशल क्लास दैट इज टुमारो. तो this is a marathon session, 3.5 hours ka, so half of the orthopedics we'll cover today. Okay, and this is for the NEET PG, but after the NEET PG we'll be having in-depth orthopedics for the prof or university going students and for the next year's NEET or the next examination. Currently I'm working as an orthopedic house surgeon in SMS Hospital Jaipur, and I have cracked the same the NEET PG examination last year, that is in 2020 only. Okay, so let's start today's session. Just I forgot to put my charger. Wait a second. Yeah, okay. So let's start today's session, and today's session को start करने से पहले I will just briefly guide you about our subscription plans available for NEET PG at Unacademy. Okay, now for the NEET PG at Unacademy we have two types of subscription plans. The first paid subscription is the Plus subscription, in which you will get access to all our live and recorded classes, all our QBanks, both of which are formed by the topmost educators for NEET PG in India. You can compete in live tests and quizzes, and also we'll allow the students to log in to multiple devices with the same account so that they can study on any device of their choice at any time. And also for the subscribers who will be subscribing for 12 months or more, we'll be shortly giving them the printed notes, and you can use this code while subscribing to get extra 10% off. Now second one and the best one is the iconic subscription, and it is best not only on Unacademy but on any digital platform across India. In this subscription, apart from the things that I have mentioned you earlier, in extra you will get prep ladder and all of the prep ladder, including all its QBanks, the video lectures, the tests, the questions, rapid revision courses, etc. All the things will be included. And on Unacademy in extra you will get well structured live batch wise classes where we have formulated batches, and we have strategized a syllabus in such a way so as to build your basic concept about any subject first and then going into its in-depth analysis. And also after every test the iconic subscribers would get a detailed individual analysis, okay, so that you can assess your test and you can find your lacunas, you can see where you are lagging behind. Okay, so this is about the iconic subscription. And also we have special classes. And what is this special features of the special classes? Here you'll get live classroom like feel even in the COVID times. These are very interactive classes where you can interact with your educator, solve your doubts there and there only. You can participate in polls, you will never miss because we'll notify you, and you can watch it anytime just by opening your Unacademy mobile application. Okay, so for this you just need to download the app and subscribe using my code here, and both of which are absolutely free. Okay, now keeping in mind the different sets of a bunch of students who are preparing for different examinations like FMG or next year's NEET PG or usse bhi aage ka next examination or the NEET PG for this year, we have formulated dedicated batches to all of the following examinations, and you can subscribe for these packages using this code to get extra 10% off. Now as you all know, hardly 7 days are left, so we had formulated a 1 month package for the NEET PG for this year's, and believe me, this is the best thing for the last time preparation for the NEET PG. It includes all the last minute tips and tricks, the high yield MCQs and the topics, the recent updates and the advances, the grand tests, the rapid revision courses, clinical based questions, the x-rays, images, everything that you need is available here. So you can subscribe for this package, this course, using this code to get extra 10% off. And we are running two special limited time period offers, in which first one, for any subscribers who will be subscribing for 12 months or more, they will be getting the 2-month subscription of that course absolutely free. And for our MBBS students, we have started a 4-year subscription package, and it is available for just 75,000 for the 4 years, and that to the iconic subscription, and the plus subscription for just 60,000 for the entire 4 years. And also this is the rate structure of a 2 courses, and here you can see, if you increase the duration of your course, the cost per month decreases significantly, and it is very useful economically as well as for the MBBS students who are just starting their preparations. Please buy a course which have longer duration of action. Okay, you can subscribe for these courses and you can use this code to get extra 10% off. ओके, सो लेट्स स्टार्ट टुडे सेशन. मैराथन सेशन है, सिर्फ नीट पीजी के काम की बात करेंगे. ओके, सो बट इफ यू हैव एनी डाउट यू कैन एनी टाइम type in the live chat box. Okay, I will be happy and I will try to solve your doubts here only. Okay, so let's start today's session and let's crack NEET PG with Unacademy. Okay, तो सबसे पहले we will study about the fracture of the clavicle and the humerus. ओके, सो क्लेविकल के लिए सबसे इम्पॉर्टेंट बात जो आपको ध्यान रखनी है, इट इज द ओनली लॉन्ग बोन which have the membranous ossification, एंड जनरली इसका फ्रैक्चर होता है ड्यू टू ट्रॉमा, ड्यू टू रोड ट्रैफिक एक्सीडेंट और फॉल ऑन शोल्डर और एन आउटस्ट्रेच्ड हैंड. ओके, द कॉमनेस्ट साइट इज द जंक्शन ऑफ मिडिल एंड आउटर 1/3, बट इससे भी बेटर ऑप्शन विल बी द मिडिल 1/3. ओके, मिडिल 1/3 सिर्फ अकेला ऑप्शन में है तो दिस विल बी योर फर्स्ट प्रायोरिटी, एंड अगर ये नहीं है तो सेकेंड बेस्ट आंसर विल बी द जंक्शन ऑफ द मिडिल एंड द आउटर 1/3 और द लेटरल 1/3. और मिडिल 1/3 पे सबसे कॉमनली क्यों होता है, बिकॉज हियर द बोथ इट इज अ कर्व्ड, here you can see ये curve bone होती है, so both the curves meet, it is the entry point of the nutrient artery, so it is the most common site. And एक और important चीज कि जो outer या lateral fragment होता है, it is pulled downwards and medially, whereas the inner or the medial fragment is pulled upwards and laterally. किसकी वजह से? This here there is pull of pectoralis major muscle, and here there is pull of sternocleidomastoid muscle. Very important for examination, ये ध्यान में रखना है आपको. Okay, now diagnosis. In the starting of the session only I am telling you कि हर फ्रैक्चर का डायग्नोसिस कैसे करना है, and it is common to all fractures which we will study today. Okay, सबसे पहले you have to correlate with the history given by the patient of trauma etc. with the clinical signs and symptoms like pain, swelling, crepitus or deformity. Okay, then you have to go for the x-ray and you have to correlate all these things with the x-ray findings. This is the way you do diagnosis. अब कोई भी मरीज with a fracture have come to your emergency department, the most grievous early complication of any fracture is your vessel injury or the nerve injury. तो सबसे पहले आपको peripheral vessels check करनी है and peripheral nerve का test by the motor functions and sensory functions you have to test. Okay, so सबका diagnosis ऐसा ही होता है. अब treatment में first of all remember all open or compound fractures you have to go for the surgery, and in closed fractures अगर फर्स्टली बात करते हैं अपन क्लोज में, बच्चों में. इन चिल्ड्रन closed and undisplaced fractures are always treated conservatively, and even mild displacement is acceptable due to remodeling. And agar there is displacement, you have to go for displacement or the epiphyseal injury, you have to go for the surgery. Similarly in adults, same with adults also. बस एडल्ट्स में एपिफाइजल की जगह क्या आ जाएगा, इंट्रा आर्टिकुलर फ्रैक्चर्स, दे यू हैव टू गो फॉर द सर्जरी. ओके, सो ये यहाँ पे भी क्या होगा, द क्लेविकल इज बोन विच वेरी रेडिली यूनाइट्स. Okay, it very readily unites, and treatment is conservative, and conservative by figure of 8 bandage. Okay, याद रखना है, for the clavicle fracture typically figure of 8 bandage, also called as the clavicle brace. Okay, early complications we have read subclavian vessels or the brachial plexus injury, and the late complication, the commonest is the stiffness. कोई भी फ्रैक्चर हो उसका मोस्ट कॉमन कॉम्प्लिकेशन जो होता है वो होता है उस फ्रैक्चर से सबसे पास वाले जॉइंट की स्टिफनेस. Okay, it is applicable to every type of fracture, so remember this. Okay, now malunion या non union हो गया, तो you have to generally, if there is malunion, so it is only a cosmetic condition, otherwise by proper physiotherapy and all you can live with it. But if it is malunion or a non-union or unacceptable malunion, you have to go for the surgery with open reduction and internal fixation by plating. Okay, now scapula fractures, 4 parts होते हैं scapula के जहाँ पे fracture हो सकता है. First is your body, you can see in the diagram, body, neck, and the 2 processes, these are the acromion process which articulates with the clavicle, and the coracoid process which articulates with the coracoacromion joint भी होता है, acromioclavicular joint भी होता है. Okay, so these fractures are mostly undisplaced, and conservative treatment 80 to 90% cases में और इससे भी ज़्यादा में the conservative treatment is advisable, and it is done by a sling or a triangular sling or normal sling, or आजकल pouch arms you can use. Okay, this is the scapula. So स्कैपुला में अब एक खास बात ये होती है कि why there is very little displacement and why mostly it is managed conservatively, because it have a thick muscle cover, and due to which it have a very rich blood supply. Okay, so इसकी वजह से conservative management is done and there is very little displacement. Remember this about the scapula. Now sternoclavicular joint यहाँ पे होता है, और कई बार very violent trauma में there is displacement. और कैसा clinically you can see here in the image also, as you can see the pain, swelling and deformity here, and here also you can see the displacement, and most commonly the displacement is forwards. Okay, and what is the treatment? You have to relocate it by just direct pressure, and then reduction is maintained by giving compression यहाँ पे by figure of 8 bandage. Okay, remember recurrence common होती है but कोई disability नहीं होती है, because it is not important for any function. Okay, now acromioclavicular joint का डिसलोकेशन और सबलक्सेशन. तो इसमें आपको एक ही चीज याद रखनी है, जनरली 8 mm तक दोनों के बीच में, बिटवीन द एक्रोमियन एंड द क्लेविकल, इन दोनों के बीच में 8 mm डिस्टेंस रहता है. इफ इट इज मोर देन 8 mm, इट इज called as the acromoclavicular dislocation, and ये किसकी वजह से होता है, यहाँ पे ligaments की इंजरी की वजह से obviously, and there are two major important ligaments. First is the acromoclavicular ligament and second is the coracoclavicular ligament, और इन दोनों में से पूछा जाएगी which is most important. Remember, coracoclavicular ligament is more important. ओके एंड ये 3 ग्रेड्स में डिवाइडेड है, ये आपके किसी काम की चीज नहीं है, बस आपको इतना सा याद रखना है कि 8 mm and which two important ligaments, and इसका ट्रीटमेंट इज immobilization. Okay, grade 1 grade 2 injuries, immobilization, and if there is grade 3 में क्या होगा, complete tear of ligaments with even the joint capsule. So उसमें you have to go for the surgical repair if the person is athlete or he or she uses this joint very frequently. नाउ नेक्स्ट इज फ्रैक्चर ऑफ द सर्जिकल नेक ऑफ द ह्यूमरस. सो उससे पहले अपन को पता होना चाहिए कि ह्यूमरस में देयर आर टू नेक्स, द एनाटॉमिकल नेक एंड द सर्जिकल नेक. दीज आर कंफ्यूजिंग, सो लेट्स डिस्कस दिस फर्स्ट. इसमें क्या होता है, द एनाटॉमिकल नेक ए पहले आता है इससे, इसलिए द एनाटॉमिकल नेक इज अपर साइड और उसके नीचे सर्जिकल नेक आती है. सो एनाटॉमिकल नेक में क्या होता है, द हेड, इसकी definition of anatomical neck is it is that part of the proximal humerus which separates the head of the humerus with the greater tuberosity and the lesser tuberosity. Okay, and surgical neck, this is anatomical neck, and surgical neck is that part of the proximal humerus which separates the shaft or the point of starting of the shaft with both the tuberosities. This is the surgical neck, and इन दोनों में से surgical neck का fracture is more common than anatomical neck, and ये भी generally किसमें, elderly women के अंदर होता है due to fall on the shoulder. Okay, elderly women के अंदर होता है, and in majority of the cases these are undisplaced or impacted fracture. Okay, so what is the treatment में वही conservative pouch arm or the U slab you can use and immobilize it for 1 week in slab, then 3 to 4 weeks in the cast, followed by physiotherapy. बहुत important है. Now proximal humerus के लिए एक बहुत important classification है which is called as the NEET classification. याद रखना, this is for the fracture of proximal humerus, एंड नीर के हिसाब से ह्यूमरस के बेसिकली 4 पार्ट्स होते हैं. ओके, फर्स्ट इज योर शाफ्ट, सेकंड इज योर हेड, थर्ड इज योर जीटी, फोर्थ इज योर एलटी. और इनके फ्रैक्चर के हिसाब से देयर कैन बी 1 पार्ट फ्रैक्चर और 2 पार्ट फ्रैक्चर और 3 पार्ट 4 पार्ट फ्रैक्चर एंड सो ऑन. सो दिस इज योर नीर क्लासिफिकेशन. जस्ट रिमेंबर द नेम, कहाँ पे यूज होता है, पार्ट्स के हिसाब से इट इज कॉल्ड एज द नीड क्लासिफिकेशन. एंड ट्रीटमेंट वी हैव डिस्कस्ड. एंड अगर डिस्प्लेसमेंट ज़्यादा है या कम्यूटेटेड है, यू हैव टू फिक्स इट बाय द सर्जरी, एंड दिस कैन बी डन बाय मल्टीपल के वायर्स और बाय प्लेटिंग. ओके, और बाय प्लेटिंग. Here you can see, here are the different methods of fixation of surgical neck of humerus. You can do the plating, the screw, the wires. This is a type of plate only. Okay. Now fracture of the GT, that is the greater tuberosity of the humerus. इसमें आपको जो बात याद रखनी है वो रखनी है कि if it is displaced, it is displaced by pull of which muscle? It is displaced by the pull of सुप्रास्पाइनेटस मसल, यानी रोटेटर कफ का अटैचमेंट होता है. ग्रेटर ट्यूबरोसिटी पे क्या, रोटेटर कफ मसल्स का अटैचमेंट होता है, दैट टू सुप्रास्पाइनेटस मसल. एंड विथ डिस्प्लेसमेंट शोल्डर डिसलोकेशन के साथ में फ्रैक्चर जीटी भी है, तो उसको रिड्यूस करने के लिए वी यूज अ मैन्यूवर, एंड उसका नेम इज इम्पॉर्टेंट. Generally in dislocation of the shoulder, the maneuver used is the Kocher's maneuver. अपन देखेंगे अभी आगे. But if the dislocation is associated with the fracture of the GT, we use Hippocrates maneuver. Okay, we use Hippocrates maneuver. Remember this. ट्रीटमेंट सेम सबके जैसा है, ट्रायंगुलर स्लिंग और द यू स्लैब कंजर्वेटिव मैनेजमेंट होता है, बट इसके लिए देयर इज अ स्पेशल टाइप ऑफ कास्ट दैट इज यूज्ड, जिसमें द शोल्डर इज abducted in a plaster cast, and see like this is for the cast of GT. Okay, here you can see fracture of GT with the greater tuberosity. Now very important is the fracture of the shaft of the humerus. Okay, fracture of the shaft of the humerus can occur in any age, and it is called as the prototype fracture. Why it is called as the prototype fracture? Because it can occur in any form, like किस किस फॉर्म में हो सकता है? It is can be oblique. Okay, it can be oblique, transverse, spiral, commutated, etc. In every form it can be done, and most common cause is obviously the trauma due to the direct force or fall on an outstretched hand, or the twisting force or the bending force. Okay, ये सारी चीजें हो सकती है the that causes the shaft of humerus fracture. Okay, humerus typical long bone होती है, and humerus पे for insertion of deltoid there is deltoid tuberosity at the anterior lateral surface, and at the posterior surface you have groove for the radial nerve. You have a shallow groove for the radial nerve. Okay, and like scapula, humerus is also surrounded by a thick cover of muscles. Okay, and this allows the increased healing because of increased blood supply and periosteum. Also malunion, जो low degree of malunion or can be masked due to the thick muscle cover, and also there is less incidence of compound fracture. Okay, now this is a prototype fracture, अपन ने डिस्कस कर लिया क्यों, वो भी डिस्कस कर लिया. एंड मोस्ट कॉमनली डिस्प्लेसमेंट जो होता है, इट हैव अ lateral angulation. ओके, एंगुलेशन होता है, एंड दैट टू lateral angulation, and it is due to the pull of deltoid muscle. Okay, due to the pull of which muscle? Due to the pull of deltoid muscle. Remember this, lateral angulation hota hai. Okay, here you can see the lateral angulation. Now diagnosis, इसमें याद रखना है wrist drop. कोई भी ह्यूमरस फ्रैक्चर होता है उसमें सबसे पहले ऑर्थोपेडिशियन जो होता है उसका रिस्ट ड्रॉप चेक करता है. द रेडियल नर्व पाल्सी के चांसेस आर वेरी वेरी हाई इन केस ऑफ ह्यूमरस फ्रैक्चर. और ह्यूमरस में भी एक स्पेशल पॉइंट है, दैट इज द जंक्शन ऑफ द डिस्टल 1/3 एंड द मिडिल 1/3, जहाँ पे के फ्रैक्चर पे देयर इज हाई चांसेस ऑफ हैविंग रेडियल नर्व इंजरी और द रिस्ट ड्रॉप. एंड उस फ्रैक्चर का एक इम्पॉर्टेंट नाम होता है. सो आफ्टर जस्ट लाइक अराउंड 5 minutes वी विल बी डिस्कसिंग दैट. सो आई एम गिविंग यू टाइम कि if anybody of you know, you can type in the live chat box. Okay, now treatment वही actually क्या होता है, I have already told you that conservative treatment is done most oftenly, and it is the treatment of choice for humerus shaft of humerus fracture because the reasons we have discussed abhi. And in general also the upper limb fractures are treated more conservatively as compared to the lower limb fractures, because क्योंकि लोअर लिम्ब में अगर माल यूनियन होगा तो आपके वॉकिंग और रनिंग और इनमें यू विल फील इट ड्यूरिंग वॉकिंग एक्सेट्रा. बट अपर लिम्ब में क्या होता है, सम अमाउंट ऑफ शॉर्टनिंग और द माल यूनियन कैन बी अनडिटेक्टेड और उससे काम चल सकता है, बट लोअर लिम्ब में काम नहीं चलता है. ओके, सो फर्स्ट ये चीज आपको याद रखनी है. सेकेंडली ह्यूमरस में क्यों कंजर्वेटिव ट्रीटमेंट होता है, वी हैव ऑलरेडी डिस्कस्ड. ओके, नाउ ट्रीटमेंट वी हैव डिस्कस्ड। अब कंजर्वेटिव मेथड्स भी कैसे ट्रीट करते हैं, एंड इसमें बहुत इंपॉर्टेंट स्लैब होती है, दैट इज द यू स्लैब। यू शुड नो हाउ टू पुट द यू स्लैब, और ये कैसे होती है। यू स्लैब स्टार्ट्स फ्रॉम द नेप ऑफ द नेक to the lateral border of the arm, round around the elbow like this, and some part of the medial side. Okay, so ऐसे from here to here, this is your U slab, like in the U shape. Okay, and lateral side में पूरा क्यों रखा है, to prevent the lateral angulation. Now there is hanging cast. Hanging cast, this is your U slab. You can see in the image, this is your hanging cast, in which from the mid arm in 90 degrees, U slab भी 90 degrees में लगता है, in the mid arm till only your wrist, not till your fifth metacarpal head, only till your wrist, it is your hanging cast. And generally distal 1/3 or lower 1/3 fracture of humerus may use this. And third is the chest arm bandage, जिसमें the arm is strapped to the chest like this. Okay, and it is used generally in children. Now operative methods. Operative method, if the fracture is commutated or there is any nerve injuries or it is open, commutated or open, or vessel or nerve injury, or there is malunion or non-union, you have to go for the operative purposes. And operation में most commonly what you do plating. Okay, you do plating. ठीक है, it is very important. And secondly, you can also do nailing, but the surgery of choice is your plating. Okay, now complications, very important, and complication is your radial nerve palsy. Okay, and generally it is neuropraxia only, yani the axons are not injured, and the spontaneous recovery occurs in almost 100% of the cases. Now we have discussed कि middle 1/3 and distal 1/3 के junction पे humerus fracture have the highest probability of the radial nerve palsy of the wrist drop, and such fracture is called as the Holstein-Lewis fracture. Okay, it is called as the Holstein-Lewis fracture. आपको name याद रखना है. Okay, now treatment of the nerve injury का treatment in mostly fractures, especially the closed fractures, it is neuropraxia only, and it recovers spontaneously. But if it is open, exploration is required, and if it is neglected or presented late, or if there is failed repair, you have to go for the nerve transfer or the tendon transfer surgery. And इसमें सिर्फ आपको नाम याद रखना है, modified Jones transfer is the most popular or the most common one, that is modified Jones. And tendons जो आप ट्रांसफर करते हो उसमें most common is the pronator teres followed by the extensor carpi radialis brevis, ये दो. Okay, pronator teres. See in this image, in this way टेंडन ट्रांसफर इज डन. इसके डिटेलिंग में आपको नहीं जाना है फॉर द नीट पीजी. डिलेड एंड नॉन यूनियन वी हैव ऑलरेडी डिस्कस्ड व्हाट वी विल डू. नाउ द शोल्डर जॉइंट एनाटमी. शोल्डर गर्डल जो होता है, इट इज फॉर्म्ड made up of 3 bones. The shoulder girdle is made up of 3 bones. First is the clavicle, scapula, and the humerus. Here you have the acromioclavicular joint. This is your glenohumeral joint or the shoulder joint proper, and this is your coracoid process, and this is your sternoclavicular joint. Okay, this is your shoulder girdle. And shoulder girdle में shoulder joint जो होता है, it is a ball and socket joint. Okay, it is ball and socket joint. यहाँ पे at the acromioclavicular joint we have already discussed कि 2 important ligaments होते हैं. First is the acromioclavicular ligament, and more important wala is the coracoclavicular ligament. And coracoclavicular ligament is divided into two parts. ये भी important है. First is the conoid part and second is the trapezoid part. Okay, so and it is most important for the stability of the acromoclavicular joint. Okay, now we have discussed about the anatomical neck. We have already surgical neck, and surgical neck ka fractures are more common. We have discussed this. Okay, glenohumeral joint between scapula, glenoid cavity and humerus ka head. Now it is a ball and socket joint, and remember ki glenoid cavity is smaller as compared to the head of the humerus. So see, this is glenoid cavity and this is your head. Okay, so it is very large. So इसके कुछ फायदे भी है, इसके कुछ नुकसान भी है. Generally the ratio is 1:4. 4 part is 1:4 between the glenoid cavity and the head. So it allows more range of movements, but it also makes the joint very unstable. तो इसकी stability को बढ़ाने के लिए what you have the joint capsule, but it is also lax, allowing more range of movements, and there are various ligaments which we'll study. Okay, and there is glenoid labrum. अब glenoid cavity के चारों तरफ there is a cartilaginous sheet, that is fibrocartilaginous in the glenoid fossa. So this glenoid fossa के चारों तरफ at the periphery there is the sheet which forms the glenoid labrum, and this deepens the fossa. This deepens the fossa to make this joint more stable. Okay, so joint cavity anatomical neck to the glenoid rim तक होती है, and it is legs. Then इसके नीचे there is synovial membrane which releases synovial fluid between the articular surfaces to lubricate it. And what are bursas? Bursas are fluid filled sacs. And what is this fluid? This is the synovium. Okay, so every joint have bursas, and the shoulder joint have some important bursas, and first and the most important is the subacromial bursa. ये सबसे इम्पोर्टेंट है. क्यों सब एक्रोमियल बर्सा है? तो ऑब्वियसली एक्रोमियन प्रोसेस के नीचे होगा, एंड इट इज इम्पोर्टेंट बिकॉज इट सप्लाइज the joint capsule, and subacromial bursitis leads to impingement syndrome or the painful arc syndrome due to rotator cuff इन्फ्लेमेशन. ठीक है, रोटेटर कफ में भी इन्फ्लेमेशन हो जाता है. एंड पेनफुल आर्क सिंड्रोम में देयर इज पेन इन मिड अबडक्शन दैट इज बिटवीन 60 to 120 degrees. Okay, so remember subacromial is the most important for the rotator cuff tendons, and इसके bursitis से there is painful arc syndrome, impingement syndrome और supraspinatus syndrome. Another is subscapular bursa between subscapularis and the scapula. Okay, here you can see in the image, this is your coracoid process, this is your acromial process, this is your clavicle, this is your clavicle, this is your coracoid process or acromion process. acromioclavicular joint, यहाँ पे दो ligaments है जिसमें से important one is the coracoclavicular ligament. ठीक है, between coracoid and the clavicle, coracoclavicular ligament, and one is the acromioclavicular ligament. Okay, here acromion process के नीचे there is bursa which is called as the subacromion bursa, और इसके नीचे there is subcoracoid bursa. ओके, सो वेरी इंपॉर्टेंट. एंड इसमें सरफेस मार्किंग आपको एक मसल की आनी चाहिए, दो मसल की बेसिकली. फर्स्ट इज द सबस्कैपुलरिस मसल, जो तो एक शीट फैन जैसी मसल जो पूरे स्कैपुला को कवर करेगी, दैट इज योर सबस्कैपुलरिस मसल. एंड द सुप्रास्पाइनेटस मसल विल बी लाइक दिस. Now horizontal, this will be your supraspinatus muscle. Okay, so rotator cuff muscles are very important. So there are four muscles that make the rotator cuff. इसके नेम तो आपको याद होने ही चाहिए. And these four muscles are, first is your supraspinatus. So supra है तो infra भी होगी, so second is the infraspinatus, and third is again SS, that is subscapularis, and third one is the teres minor. Remember, third one is the teres minor. These are the four muscles of the rotator cuff. Okay, here in this diagram you can again see all the things that we have discussed. You can even see the two parts of the coracoclavicular ligament, that is the conoid part and the trapezoid part. Okay, so anatomical neck and surgical neck we have already discussed. Okay, so this here x-ray में finding आना is very important. This is your clavicle, this is your acromion process, this is your coracoid process, this is your humerus, ये head है, ये anatomical neck है, ये surgical neck है, this is your GT, this is your LT, this is your shaft. Okay, this is your scapula, and यहाँ पे it is your glenoid cavity of the scapula. Okay, so very important, remember the x-rays में you need to identify the structures. Now stability के लिए there are various other ligaments. First is the glenohumeral ligament, which gives the stability to the shoulder joint proper because it makes the joint capsule. Okay, very important, and it prevents the anterior displacement of the joint. Second is between coracoid process and the humerus head, that is the GT, and it is coracohumeral ligament. Transverse humeral ligament between the two tuberosities, matlab between GT and LT, there is transverse humeral ligament, और इस transverse humerus ligament के नीचे से long head of biceps निकलता है. Important is कि transverse humeral ligament के नीचे से long head of biceps निकलता है. Coracoclavicular ligament we have discussed. Now another is the coracoacromial ligament, and it forms the coracoacromial arch, and it prevents the superior displacement of the humerus head. Okay, so superior direction में stability देता है coracoacromial ligament, and anteriorly the joint capsule or the glenohumeral ligament, remember. Okay, so these are the different ligaments between coracoid process and the humerus, joint capsule or the glenohumeral ligament, the coracoacromial ligament, the acromoclavicular, this is the coracoclavicular ligament, coracoacromial ligament जो superior नहीं जाने देगा, ये anterior नहीं जाने देगा. Okay, this is subacromial space where there is subacromial bursas. Okay, now movement, ball and socket joint है, so shoulder joint is the most mobile joint in the body. Every plane में there is movement. अब movement को समझने से पहले first you have to know the various planes that are available, sorry not available, various planes that are used. First you need to know about this. Okay, so first of all, there is sagittal plane. Sagittal plane कैसे होता है? The sagittal plane is like this. This is a sagittal plane which divides your body into right and left. This is called as the sagittal plane. Very important. Okay, so this is your sagittal plane, and mid sagittal अगर mid point से कर रहे हैं, अगर mid point नहीं है तो parasagittal. And this now superior inferior, this is your transverse plane or the horizontal plane, this is your transverse or the horizontal or the axial plane. Okay, and the third one is the this this, like this. So this is your frontal plane which divides body into anterior and posterior parts. राइट और लेफ्ट के लिए sagittal है और anterior and posterior के लिए frontal और the coronal plane. Okay, very important, frontal plane or the coronal plane. So the extension जो होता है shoulder joint का, it is like this, extension flexion. So it is in the sagittal plane and the abduction is in the frontal plane or the coronal plane, like this. Okay, so इसमें अलग अलग muscles काम आती है. So at the last time you need to remember very importantly at least the abduction muscles. Okay, so it is in the coronal plane and abduction of the shoulder joint is very important. Okay. For 0 to 15 degrees of abduction is done by the supraspinatus muscle. 15 to 90 degrees is done by the deltoid and uske bhi kaun se middle fibers of the deltoid, and above 90 degrees, that is your overhead abduction, is done by serratus anterior and the trapezius. Very important. Okay, so 15 degrees supraspinatus, 15 to 90 middle fibers of the deltoid, and 90 से ऊपर overhead abduction by the serratus anterior and the trapezius muscle. At least remember this. This is a very important. Flexion and extension we have already discussed. ऐसे तो it occurs in the sagittal plane. Okay, now adduction and abduction. Adduction, this is abduction, this is adduction, this is internal rotation, and the thumb will point laterally obviously, and this is your external rotation. Okay, now the mobility and stability we have discussed कि most mobile joint है, but it is the most common joint to get dislocated. Most common joint to get dislocated is your shoulder joint. Okay, now stability के लिए rotator cuff muscles है, ठीक है, we have discussed them. And a resting tone of these muscles is important because the resting tone of these muscles, they compresses the humeral head into the glenoid cavity, glenoid labrum, various ligaments, and the biceps tendon also. Now these are the rotator cuff muscles, the subscapularis, supraspinatus, infraspinatus, and the teres minor. Now neurovasculature, not so important. The blood supply है anterior and posterior circumflex humeral artery, which are branch of the subclavian artery की branch हो जाती है, sorry, the axillary artery, और axillary artery खुद भी terminal branch है subclavian artery की. Okay, and nerves is the axillary, suprascapular, and the lateral pectoral nerves. Glenohumeral joint, we have already discussed everything about it. Now shoulder dislocation, 15 minutes की shoulder dislocation की special rapid revision. I think yesterday or day after yesterday I have uploaded it, so check it. अपन वापस से जल्दी से रिवाइज कर लेते हैं. Most common joint to get dislocated is shoulder joint, and most commonly it gets dislocated anteriorly, whereas hip and elbow joint most commonly gets dislocated posteriorly, and anteriorly maybe most common is the subcoracoid type. Okay, subpreglenoid, subcoracoid, and intrathoracic and subclavicular, 4 types होते हैं, उसमें से subcoracoid is the most common. Okay, anterior dislocation. And now there is one term that is MDI, multidirectional instability, most common in the shoulder joint because it can be dislocated or subluxated in any direction. Now subluxation and dislocation में क्या फर्क है? अगर अपनी जगह से partially ही हटा है, this is your subluxation, and if it is completely removed from the normal location of the articular surfaces are completely not in alignment with each other, it is called as the dislocation. Okay, anterior में anteriorly आ जाएगा, posterior में posteriorly चला जाएगा. Very easy to identify. Okay, now there will be widening of the glenohumeral space here. Okay, and this is your shoulder dislocation. Now mechanism, most common is your trauma, mostly due to direct trauma, fall on an outstretched hand or due to direct trauma. And if it is anterior, so anterior dislocation के अंदर humerus head will be forced outwards anteriorly, so your shoulder will be abducted and externally rotated, or posteriorly में obviously adducted and internally rotated. Okay, so anterior dislocation का classification we have discussed, and the most common is the subcoracoid part. Here you can see this is your subcoracoid part. Okay, now this is your anterior dislocation and this is subglenoid type. Posterior dislocation में खास बात जो आपको याद रखनी है, it occurs after convulsion or seizures or epilepsy or very important electric shock. Okay, this is very important and it is posterior behind the glenoid, and इसमें you have two signs. First is your electric bulb sign, इलेक्ट्रिक शॉक से होता है इसलिए इलेक्ट्रिक बल्ब साइन मिलेगा. एंड सेकेंड वन इज योर एम्प्टी ग्लेनॉइड sign, and second one is your empty glenoid sign. Very important. Okay, now third one, rare one but important for examination, it is inferior dislocation. Okay, subglenoid position में, and इसका एक special नाम है जो very important है, and नाम is luxatio erecta. Okay, luxatio erecta. Remember name ki what is luxatio erecta, important for your examination point of view. Okay, now pathological changes with anterior dislocation. Sometimes there are certain pathological changes which are seen, and the most important is the Banker's lesion. Very important. इसमें क्या होता है, glenoid rim, so with dislocation there is some injury to that glenoid labrum wala part, and most commonly that injury is at the anterior inferior surface. Okay, so anterior inferior surface पे होगा and injury to the glenoid labrum, and sometimes there is avulsion of a bony chip also, and this is called as the bony Bankert lesion. Okay, it is called as the bony Bankert lesion. Here you can see this is your Bankert lesion. Okay, second is the Hill-Sachs lesion. There is in Hill-Sachs lesion there is a depression in the humeral head, and it is in the posterior lateral quadrant. Okay, वो anterior inferior में था, ये posterior lateral quadrant में हो जाएगा. There is depression, and in recurrent shoulder dislocation there is rounding off of this glenoid labrum, and that too at the anterior side, जिससे वो stability या वो hold नहीं आता है shoulder joint में, and there is recurrent shoulder dislocation. Okay, so remember this image. This is Bankert lesion, so ये क्या होगा, posterior lateral है, image में दिख रहा है, and this is your Hill-Sachs lesion, and this is your Bankert's lesion, which is anterior inferior. Very important, remember these two. Okay, now diagnosis I have already told you. The when you'll examine you can see जो normal round contour होता है shoulder joint का, that is lost and the round contour has become flattened. And for testing the anterior dislocation we have two very important tests. First one is the Dugas test. इसमें क्या होता है, generally opposite shoulder को you can touch with the fingers of your opposite limb like this. But if my this hand, that is my right hand, if it is dislocated, I will not be able to touch the fingers of this hand on this shoulder. This is your Dugas test. And second is the Hamilton ruler test, in which generally क्या होता है, generally this is round contour, so a straight ruler or scale को अगर आप लगाते हो तो it is not possible to hold it here, but there is flattening of this contour in dislocation, and you will be able to place the ruler or scale. This is called as Hamilton ruler test. Okay, now posterior dislocation convulsion के पास होता है, we have already discussed. And कहीं का भी dislocation हो anywhere in the body, the treatment of choice is closed reduction, generally under GA, short GA, followed by immobilization. But if there is intra-articular chip, or it has failed, okay, or if there is recurrence etc., you have to go for the surgery. अब यहाँ पे shoulder dislocation के लिए we have two types of maneuvers. First is the Kocher's maneuver. First is your Kocher's maneuver, second is your Hippocrates maneuver. Kocher's maneuver is the bread and butter, it is used. Hippocrates maneuver में क्या होता है अलग से, the foot is used and foot से आपके एक्सिला के अंदर प्रेशर लगाते हैं. सो उस आपको सिर्फ इतना पता होना चाहिए, नेम पता होना चाहिए, and तीसरी चीज़ ये पता होनी चाहिए, अगर shoulder dislocation के साथ there is associated fracture of the greater tuberosity, then Hippocrates maneuver is used. Now Kocher's maneuver के लिए you need to learn a mnemonic that is T1. T1, firstly there is traction. Okay, traction is sustained traction with semi-flexed elbow, and remember कि traction, sustained traction आपको हर reduction से पहले, be it of the joint or any bone, you have to give at least 5 to 10 minutes of the sustained traction to relax the muscles. And then E for external rotation, you'll, after the sustained traction, you'll externally rotate the arm. Okay, after sustained traction you externally rotate the arm. Then A for adduction, and then the internal rotation. So this is your Kocher's maneuver. और एक क्लिक सुनाई देगा, या फिर जो anxious look, painful look होता है in patient's face, that will be vanished, and then you have to immobilize it, followed by your physiotherapy is very important. Okay, this is your Kocher's maneuver, this is your Hippocrates maneuver. Complications: in early complications, you can have axillary nerve injury which supplies to the deltoid, and there will be regimental badge sign. Okay, regimental badge sign you will see if there is axillary nerve palsies. And the commonest late complication is your recurrent dislocation. ओके, एंड उसके ट्रीटमेंट के देर आर वेरियस ऑपरेशंस, उसके सिर्फ नेम आपको याद होनी चाहिए. फर्स्ट इज द पुटी प्लैट ऑपरेशन, second is your Banker's operation, and third is your Bristow's operation. Just you need to remember the name. Okay, now let's do some questions in between also, ताकि आपको you will be interested. A 4-year-old child presented to the clinic with a history of fall on outstretched hand. Radiographs revealed a broken anterior cortex with an intact posterior cortex of the radius with an exaggerated bowing of the radius. The fracture sustained is. Okay, so the answer for this question is your green stick fracture. है ना। मॉन्टेजिया गैलेजी तो हो ही नहीं सकते। अब दो में कंफ्यूजन है, ग्रीन स्टिक एंड टॉरस में। सो ग्रीन स्टिक में ये ध्यान रखना है, दिस टाइप ऑफ फ्रैक्चर एंटीरियर एंड पोस्टीरियर कॉर्टेक्स की अगर बात आ जाए तो इट इज योर ग्रीन स्टिक फ्रैक्चर। एंड इफ द फ्रैक्चर इज बिटवीन दिस मेटाफाइसिस एंड डायफाइसिस वाली बात आ जाए, दोनों ही बच्चों में होता है, इन चिल्ड्रन एंड बोथ में both in occurs in children only, both are managed conservatively। लेकिन अगर यूनिकॉर्टिकल है तो इट इज ग्रीन स्टिक फ्रैक्चर एंड इट इज एट द मेटाफाइजल डायफाइजल एरिया, इट इज द Taurus fracture in children, and Taurus fracture is also called as the buccal fracture, okay, because there is buckling of the cortex, and this is your green stick fracture, okay। Galeazzi Monteggia, we'll discuss them। You can see this is your Taurus fracture, okay, this is your Taurus fracture। Now myositis ossificans is a post-traumatic ossification, it is an heterotropic ossification, also called as ectopic ossification, and myositis is a misnomer because there is no inflammation of the muscle, very important, okay। And most commonly it is due to post trauma, post surgery, or overuse injury, especially in the soleus muscles, ओके, वेरी इंपॉर्टेंट, बस इतना ही याद रखना है। एंड इसके साथ में दो टर्म्स एसोसिएटेड, उन टर्म्स का नाम याद रखना है। फर्स्ट इज द माइक्रोस्कोपिक जोन्स ऑफ सब पेरियोस्टियल रिएक्शन कॉल्ड एज द Ackermann zones, okay, called as the Ackermann zones, and second is there is metaplasia of the fibroblast due to which there is ossification at an abnormal location, this is called as the myositis ossificans। Now we'll study about the injuries around the elbow। तो सबसे पहले elbow की basic anatomy you should know, okay। तो सबसे पहले you should know about the basic anatomy of the elbow, okay। So before starting this, let's take a break of like just 30 seconds, okay। Let's take a break of 30 seconds। एक घंटा अपन ने पढ़ लिया है and we have covered pretty well। Okay, so elbow में this is your distal humerus, and on the medial side you will have the ulna, and on the lateral side you will have the radius, and this ulna and radius articulates with the distal end of the humerus, okay। Medially there is medial epicondyle, and here there is area which articulates with the ulna, which is called as the trochlea, this is important। And the area of the humerus which articulates with the radial head, it is called as the capitulum, it is called as the capitulum or the capitulum, ओके। ये important है from examination point of view। now radius में there is this radial neck and the radial neck head and the articular surfaces, and on ulna there is this olecranon part, this is the olecranon part, here you have the trochlear notch, and here very important is the coronoid process, okay, it is the coronoid process, okay। remember this, it is a hinge type of joint, and it is comprised of two joints, that is humero-ulnar joint and the humero-radial joint, okay, humero-ulnar and the humero-radial joint। now very important is the three bony point relationship, If you flex your elbow, you can feel these three bony points: the olecranon, the medial epicondyle, and the lateral epicondyle, forming an isosceles triangle. And if you extend these bony point relationship will not be seen as a triangle. They both come to lie in a single line. And in semi-flex position, there is fourth bony point that you can feel, very important, and that is your head of the radius. That is your head of the radius, felt just inferior or below to the lateral epicondyle. Okay, below the lateral epicondyle. This is your three bony point relationships. Now very important is carrying angle. Okay, see, there is an angle between long axis of humerus and long axis of ulna. This is called as the carrying angle. And cubitus valgus deformity में LRI यानी laterally the deformed limb will go, so laterally there will be increase in the carrying angle in cubitus valgus, and in cubitus varus the carrying angle will be decreased or it will be reversed. Okay, so this is your carrying angle. और ये किस में दिखता है? Fully extended and supine arm में. And if you see ना, fully extended and supine arm, it is not in the straight line. There is an angle in normal people also. This is called as the carrying angle. Males में it is 11 degrees normally, and in females it is around 14 degrees. Okay, this is your carrying angle, very important for your examination. Now stability of the elbow, वैसे joint space and various collateral ligaments and all. So इसमें one important thing is your pulled elbow. Okay, one is your pulled elbow. So pulled elbow के बारे में we'll study in the further slides, don't worry. एक ही जगह अच्छे से पढ़ेंगे अपन, है ना? Now ossification around the elbow. So elbow के around जो ossification centers है, उसका जो fusion होता है वो different types time पे होता है, and it is important, and this is क्रेटोई. ओके, इस नाम से याद रखना है आपको, क्रेटोई. एंड C for capitulum, and capitulum articulates with radius, so it is radial head. I for internal यानी medial epicondyle. T for trochlea. O for olecranon. ये trochlea articulates with ulna, and olecranon is part of ulna. And E for external यानी lateral epicondyle, and they occur in 1, 3, 5, 7, 9 and 11 years of age respectively. Okay, 1, 3, 5, 7, 9 and 11 years of age respectively. This is your ossification centers around the elbow. Mechanism of injury, there can be direct or indirect. Direct trauma or indirect fall on an outstretched hand, or there is twisting force of valgus, varus or hyperextension. Okay, now very important for examination point of view, very important is your supracondylar fracture of the humerus. Supracondylar fracture, देखो इमेज एंड नाम से पता चल रहा है दोनों कॉन्डाइल्स जो है मीडियल एंड लेटरल एपिकॉन्डाइल इससे ऊपर होगा. सो इट इज एक्स्ट्रा आर्टिकुलर फ्रैक्चर, बच्चों में बहुत कॉमन होता है. ओके, एंड इट इज वेरी सीरियस फ्रैक्चर. And very serious, why? Because there is very important early complication, that is of the brachial artery injury or the median nerve or radial nerve injury. And इसमें से भी median nerve is more important. Radial nerve से wrist drop होता है, and median nerve से you will have the pointing index or the Ochsner's index. Okay, and late complication, which is the most common complication, is the malunion. Okay, malunion of the supracondylar fracture of humerus, and it will lead to the cubitus varus deformity called as the gun stock deformity. ओके, इसलिए इट इज वेरी सीरियस। सो ये आपको याद रखना है। ओके, and during injury, if the elbow is forced into hyperextension, it will lead to the supracondylar fracture of the humerus. Okay, there are two types, extension type and the flexion type. Extension type is most common, and in this type जो distal fragment होगा, it will be displaced posteriorly, that is backwards. Okay, posteriorly, that is backwards, and all other types of displacements are possible. It is supracondylar fracture and it is lateral view. चलो अब यहाँ पे एक चीज मैं आपको बता देता हूँ, AP view and lateral view. See, this is your AP view. So AP view में there dislocation या displacement जो आपको दिख रहा है, displacement AP view में. So AP view helps you to identify medial or lateral tilt or medial or lateral dislocation, whereas the lateral view, see, this is your lateral view, this is not your medial or lateral, this is your anterior and posterior. So this is posterior, this is anterior. So lateral view will tell you about the anterior or posterior displacements, and it is applicable everywhere. Okay, and very important, supracondylar fracture के लिए you have Gartland classification. 3 types में है. If it is undisplaced, second undisplaced है लेकिन posterior cortex in touch है, and third is completely undisplaced. ठीक है, undisplaced, displaced but the posterior cortex is in line, and the third is complete displacement. Okay, now diagnosis we have already discussed. Okay, complications we have discussed. Pointing index or the Ortner's clasp finger, when you will tell the patient, ask the patient to clasp, he will not be able to clasp the middle or the mainly the index finger, so it will lead to the pointing index. And radiological features we have discussed, we have seen. Now treatment. Okay, तो जो अपन ने अर्ली कॉम्प्लिकेशन पढ़े हैं वेसल और नर्व इंजरी के, most commonly occurs during the first 2 days, that is the first 48 hours of the injury. Okay, now what is the treatment of choice? Okay, so we have discussed that malunion is a very common or the most common complication. So to prevent this deformity, the cubitus varus or the gunstock deformity, what you have to do, the क्योंकि ये हो भी बच्चों में रहा है, ठीक है, सो यू नीड अ प्रॉपर or perfect reduction. Okay, so the treatment of choice is your closed reduction. Treatment of choice is your closed reduction by proper maneuver. And how do you closely reduce it, we will discuss it. Okay, so close reduction, and then go for the check x-ray weekly and keep the patient in slab or cast. But generally or most commonly क्या होता है, these get displaced of when you see on the check x-rays. So the recent trend is towards close reduction and then fixing it by the percutaneous K wires, and then fixing it by the percutaneous K wires under IITV, that is image intensifiers और CARM. इसके बिना ये नहीं हो सकता है. Okay, so technique क्या होती है? Technique is like this. Firstly, you have to give the sustained traction in semi-flexed elbow. Counter traction देना ही पड़ेगा. Then you in holding the wrist from one hand and stabilizing the elbow, you'll flex the elbow, completely flex the elbow in supine position, feeling the tip of the olecranon, keeping pressure on the tip of the olecranon and feeling all 3 bony point relationships. Then after reducing it, you will fix it by the slab or the cast or the K wires if you are going for the surgery. The internal splint, the periosteum of the bone जो होती है, the intact periosteum and the triceps muscle acts as an internal splint. Okay, and ये याद रखना, कोई भी maneuver करो, after that maneuver you have to palpate the radial artery, radial pulse, ये चेक करने के लिए कि during your manipulation you have not injured your vessel. Okay, you have not injured your vessel. To check this you need to feel the peripheral pulse, and if it is grossly undisplaced or the closed reduction is failed, you have to open it, openly reduce it, and then fix it with the K wire. Obsolete हो गया है, पुराने जमाने में you used the continuous traction called as the Smith traction if it is through the olecranon, and if this is a skeletal traction, and a skin traction below elbow called as the Dunlop's traction. So आपको ये ध्यान रखना है कि ये दो ट्रैक्शन के नेम है जो सुप्राकॉन्डाइलर फ्रैक्चर में यूज होते थे, द स्किन ट्रैक्शन एंड द Dunlop traction and which is a skin traction, and the Smith traction which is a skeletal traction. Here you can see completely displaced type 3 fixed by K wires after reduction. Okay, so this is your Dunlop traction. Why? Because it is a no, this is your Smith traction. Why? Because here you can see this is your skeletal traction, ST pin या pin डली हुई है और उस pin से you have, this is your Smith traction. Okay, so योर ट्रीटमेंट प्रोटोकॉल इज वेरी इजी, कि आया है अनडिस्प्लेस्ड है, कास्ट लगाओ, चेक एक्सरे करो, देखो। फर्स्टली यू हैव टू फील दी नर्व्स एंड वेसल्स, और अगर वो प्रेजेंट है तो ही ये है, अगर वो एब्सेंट है then immediate exploration is required, and if it is displaced you have to closely reduce it under the C-arm, और चेक एक्सरे कराना है, और you can go for the percutaneous K wires, और ये सब भी फेल हो गया then you have to openly reduce it. Okay, complications we have discussed. Now one more complication is your if there is brachial artery injury, okay, or there is compartment syndrome, then there will be Volkmann ischemia, which is the ischemic injury to the muscles and the nerves, and the most commonly um artery due to which this occurs is your anterior interosseous artery, which is a branch of the brachial artery, and the most muscles are of the flexor compartment of the forearm, and the most commonly two muscles, flexor digitorum profundus का भी सिर्फ medial half plus flexor pollicis longus. Okay, and what will be the साइंस एंड सिम्टम्स? तो डायग्नोसिस इसका जो होता है, इट इज अ क्लिनिकल डायग्नोसिस, एक्सरे में कोई चेंजेस नहीं दिखते, सो द earliest and the most important of the pathognomic is your pain, and pain is of two types. First, एक तो it is out of proportion, that it is a very severe pain, and it is out of proportion of that pain due to fracture alone. Okay, very severe pain. And the second characteristic is it is stretch pain, और इसी को क्या को elucidate करने के लिए you do the stretch test, that is when you stretch the flexor muscles there is वेरी एग्जैजरेटिंग पेन, बहुत ज़्यादा पेन होता है, दिस इज योर स्ट्रेच पेन. फिर इसके बाद में यू गेट अदर सिम्टम्स दैट ऑफ पैलर, पल्सनेसनेस एक्सेट्रा, एंड पल्सनेसनेस कैन बी ड्यू टू हाइपोवॉल्यूमिक शॉक एक्सेट्रा, सो इट इज नॉट अ गुड इंडिकेटर ऑफ Volkmann ischemia. Now Volkmann ischemia के treatment करना is very important because it is an emergency, otherwise the muscles will go in and the nerves will go for the necrosis and the permanent damage. So सबसे पहले जो भी external splint, slab, cast, bandage कुछ भी लगा, you have to remove it, you have to elevate the hand like this. Okay, you have to elevate the hand like this, and the treatment of choice is the fasciotomy. Okay, where आप fascia जो deep fascia होता है वहां तक काट देते हो, it is your fasciotomy. Okay, late complications, malunion most common complication होता है, that will be cubitus varus deformity or the gunstock deformity, where the distal fragment जो union के बाद distal fragment will be tilted medially and internally rotated. Okay, so this is your gunstock deformity. Okay, or treatment generally physiotherapy and all say it is treatable, and it does not hamper the functions of the day-to-day life. But if it is having a cosmetic problem or it is hampering your functional ability, then there is a special type of surgery which is a supracondylar osteotomy, and इसका एक नाम है, सिर्फ आपको नाम याद रखना है, and that name is your French osteotomy. Okay, French osteotomy. Myositis ossificans भी हो सकता है, we have discussed this. Now late में there can be वोक्समैन इस्चेमिक कॉन्ट्रैक्चर, तो वहाँ पे जो इस्चेमिक चेंज इंजरी हुई थी मसल्स पे, उसकी वजह से देयर विल द मसल विल गेट फाइब्रस एंड देयर विल बी फाइब्रस टिश्यू और द फाइब्रस बैंड्स विद इंजरी टू द नर्व, सो देयर विल बी लॉस ऑफ सेंसरी एंड मोटर फंक्शंस, टिंगलिंग सेंसेशंस एंड ऑल होंगे. एंड हियर यू विल गेट अ वेरी इंपॉर्टेंट कौन सा वोक्समैन ischemic sign or the Volksmann sign. In the image you can see, अगर interphalangeal joints are in extension then only you can flex the wrist, and if the wrist is in extension you cannot flex the interphalangeal joint. Okay, so इसमें क्या होता है, it is possible to extend the fingers fully at the interphalangeal joint only if when the wrist is flexed. Okay, and vice versa. This is due to marked atrophy of the forearm muscles, especially the flexor compartment, and the skin will be dry and scaly. Okay, तो इसके लिए you have a turnbuckle splint or the Volksmann splint. Here you can see in the image, this is your turnbuckle or the Volksmann splint for the Volksmann ischemic कॉन्ट्रैक्चर. एंड एक ऑपरेशन है, उसका नाम याद रख लो बस, एंड उसका नाम है मैक्स पेज ऑपरेशन. ओके, उसका नाम है मैक्स पेज ऑपरेशन. नाउ लेटरल कॉन्डाइल ऑफ द ह्यूमरस, नाम से पता चल रहा है किस में होगा, बच्चों में होगा, बाकी सारी चीजें सेम है. ओके, एंड इट विल लीड टू लेट कॉम्प्लिकेशन, माल यूनियन अगर हुआ तो इट विल लीड टू क्यूबिटस वैल्गस डिफॉर्मिटी, एल से एल. एंड यहाँ पे क्या होता है, इसके साथ में यू विल हैव टार्डी अल्नर नर्व पाल्सी. इट इज वेरी इंपॉर्टेंट. ओके, वेरी वेरी इंपॉर्टेंट कि लेटरल में तो अल्नर नर्व होती नहीं है, फिर भी यहाँ पे टार्डी अल्नर नर्व पाल्सी होगी, बिकॉज दैट माल यूनाइटेड सेगमेंट will injure chronically or will give stress to this ulnar nerve. Okay, very important, and generally ऑपरेशन करना ही पड़ता है, because most commonly it is Salter Harris type 2. Now Salter Harris classification is used for the epiphyseal injury. कहीं पे भी epiphyseal injury होगी, so you will use the Salter Harris classification, very important. And in Salter Harris classification the epiphyseal injury is divided into 5 types. Okay, it is divided into 5 types. First straight है, सेकेंड में ओनली ग्रोथ प्लेट के ऊपर फ्रैक्चर है, थर्ड में ओनली ग्रोथ प्लेट के नीचे फ्रैक्चर है, बट इन टाइप 4 ग्रोथ प्लेट के ऊपर नीचे एंड द ग्रोथ प्लेट ऑल्सो through and through fracture is type 4, and in type 5 there is crushing of the growth plate, worst prognosis because there will be no growth of this bone. Okay, now lateral condyle fracture of humerus में ये ध्यान रखना, lateral condyle is the origin of common extensor muscles. Okay, it is the origin point of the common extensor muscles. So there will be displacement due to the pull of these muscles. Okay, see here, you can see this is your lateral condyle, okay, the lateral epicondyle. Now treatment, we have discussed it, बिल्कुल सेम वैसी होगा, conservative or closed reduction and KY or open reduction KY. Complications we have discussed already, cubitus valgus and tardy ulnar nerve palsy होगी, very important for the lateral. Other, joint stiffness, osteoarthritis, interarticular fracture of humerus, intercondylar fracture of humerus, it will be T और Y shaped. कहीं पे भी intercondylar fracture हो वैसे ही होंगे, नाम से पता चल रहा है कि intercondylar fracture जो होंगे it will be between the condyles and there will be splitting of the two condyles. Diagnosis X-ray में आप देख ही लोगे. The treatment is mainly surgical because it is intercondylar, so perfect reduction is necessary. Okay, and the main complication and the most common complication will be your stiffness of the shoulder. Okay, सब कुछ same है. Medial epicondyle of the humerus, it is more common. इसमें this is very important that medial epicondyle fracture is more common than the lateral epicondyle fracture, because it is also very important. The reason is the epiphysis of the medial epicondyle appears early and fuses late. Okay, with the medial epicondyle का जो ossification center और epiphysis होता है, it appears early and fuses late. That's why it is more common, and there will be cubitus varus deformity in case of malunion, and it is frequently associated with posterior dislocation of the elbow, another very important thing. And nerve, यहाँ से कौन सी ulnar nerve जाती है, तो ulnar nerve injury as an early complication can be seen. Now dislocation of the elbow joint, we have डिस्कस की सब तरह का हो सकता है, बट पोस्टीरियर इज मोस्ट कॉमन एंड जनरली एसोसिएटेड विद फ्रैक्चर ऑफ द मीडियल एपिकॉन्डाइल. ओके, and clinically there will be pain in the elbow and there will be bowstringing of the triceps, and in dislocation the three bony point relationship will be reversed. In supracondylar humerus fracture में तो क्या है, दोनों कॉन्डाइल के ऊपर फ्रैक्चर है, तो द थ्री बोनी पॉइंट रिलेशनशिप विल बी मेंटेन्ड. इन डिसलोकेशन इट विल बी रिवर्स्ड, यानी ऑलिगोन ऊपर से नीचे आ जाएगा. एंड इन अदर यूनिकॉन्डाइलर फ्रैक्चर्स इट विल नॉट बी मेंटेन्ड. ओके, एंड मोस्ट कॉमनली एसोसिएटेड नर्व इंजरी जो होती है, इट इज ऑफ द मीडियन नर्व. ओके, मीडियन नर्व इज द मोस्ट कॉमन नर्व injured in the dislocation of the elbow joint. Okay, and treatment is close reduction followed by immobilization and then the physiotherapy. एक इसमें important चीज that you should know, it is the terrible triad of elbow. जो आपको पता होना चाहिए, it is the terrible triad of the elbow, and in which there will be posterior dislocation with fracture of radius head and with fracture of coronoid process of ulna. Okay, very important is the terrible triad. Now pulled elbow 2 to 5 years of the age में होता है, and it is also called as nursemaid's elbow because nursemaids या parents वगैरह जब हाथ से ऐसे पुल करके बच्चों को उठाते हैं, तो the elbow gets subluxated, and it is not the subluxation of the elbow, it is just the subluxation of the radius head under the annular ligament, or the subluxation of the annular ligament itself. Okay, and the forearm will lie in a semi-pronated or the pronated position. Okay, and the patient will the child will cry, and he will not stop crying unless this is relocated. ओके, एंड ये एक्सरे में नहीं दिखता है बिकॉज द रेडियल हेड इज स्टिल कार्टिलेजिनस। ओके, रेडियल हेड इज स्टिल कार्टिलेजिनस। सो इसको आप कैसे ट्रीट करते हो? सस्टेन ट्रैक्शन देते हो, देन जो प्रोनेशन है उसको यू गो फॉर द सुपिनेशन एंड देन यू फ्लेक्स द एल्बो बाय फीलिंग द बोनी पॉइंट्स एंड you will click a certain click sound and you can see the anxious look and crying of the child has disappeared. Then you have to immobilize it for few weeks, then going for the physiotherapy. So it is very important. This is your nursemaid's elbow or the pulled elbow. Now fracture of the olecranon, olecranon यहाँ से fracture होती है, so it is olecranon में जो displacement होता है, the displacement is due to the pull of triceps muscle. Remember, it is due to the pull of the triceps muscle, क्योंकि olecranon ये posteriorly है, तो posteriorly में triceps muscle होती है. There can only be a crack with displacement and with commited fracture. So if it is undisplaced, you can go for just slab or cast, but remember 30 to 40 degree flexion में लगता है olecranon के अंदर slab और cast, very important. And if surgery के लिए the treatment of choice is, or the surgery of choice is tension band wiring or the TBW, very important. And mostly the indication is of surgery only. Okay, the indication is of surgery only. The most common complication will be your stiffness, elbow stiffness. It can go into non-union osteoarthritis. सबके पता है. Head of the radius, here you can see this is the head of the radius fracture. If it is undisplaced or crack only, conservative. If it is display, head is broken off but it is less than 1/3 of the size of the head, it can be managed conservatively. Otherwise you have to do the surgery with screw or KY insertion, and you can do the excision alone on radius head की एक खास बात ये होती है कि इसमें पेन कब होता है? इसमें पेन जब होता है when you rotate the forearm. Okay, there is painful rotation of the forearm. तो forearm के rotation के time पे there will be pain. Okay, complications for your neck of the radius fracture, same. Now we'll come to the injuries of the forearm and the wrist. Okay, now we'll come to the injuries of the forearm and the wrist. So ulna and radius दो type के होते हैं and they are common and frequently open fractures होते हैं, but generally the fractures are open from within. ये बात ध्यान रखनी है आपको. You can feel also that ulna is on the medial side and ulna is more superficial as compared to the radius. So nightstick fracture या लाठी या assault की वजह से अगर isolated fracture है of the forearm bone, it is most commonly in the ulna, that too between the at junction of distal 1/3 and middle 1/3, and इसलिए ulna is the most common forearm bone to go into the non-union. And non-union may be, what will be the site of the non-union? Between middle 1/3 and distal 1/3. ओके, और अल्ना के फ्रैक्चर को बोलते हैं नाइट स्टिक फ्रैक्चर ड्यू टू डायरेक्ट ट्रॉमा और लाठी, बिकॉज इट इज अ सुपरफिशियल बोन. नाउ वेरी इंपॉर्टेंट यहाँ पे आता है, दैट इज गैलेजी फ्रैक्चर एंड दी मॉन्टेजिया फ्रैक्चर, जो अपन अभी पढ़ेंगे. नाउ एक और इम्पॉर्टेंट चीज जो याद होनी चाहिए वो होनी चाहिए कि जो रेडियस है, इट इज वेरी इंपॉर्टेंट. रेडियस के proximal end पे there is attachment of the supinator muscles, and in the middle 1/3 or in the middle part there is attachment to the pronator muscles. Okay, there is attachment to the pronator muscles. So ये आपको याद रखना है इतनी सी चीज. Okay, Here you can see forearm में proximal and distal दो radial ulnar joints होते हैं, radius होती है, ulna होता है. This is your supination, this is your pronation and supination. Supination कराने वाली muscles proximally attach होती है radius के, and pronation कराने वाली मिडल एंड डिस्टल पार्ट में होती है. ओके, मोस्ट कॉमनली ये दोनों बोन्स एक साथ फ्रैक्चर होती है, कॉल्ड एज द बोथ बोन फ्रैक्चर ऑफ बोथ आर्म, फ्रैक्चर बोथ बोन फोर आर्म. ओके, बाय लाठी. सो बच्चों में जनरली इट इज अ ग्रीन स्ट्रिक फ्रैक्चर. दिस मैनेज कंजर्वेटिवली, वी हैव डिस्कस्ड. एंगुलेशन, शिफ्ट, रोटेशन सब हो सकता है. मोस्ट कॉमनली द एंगुलेशन इज towards the medial and anterior side. Treatment, if it is undisplaced, you can go for the conservative management. Okay, conservative management, slab or cast. और मैनिपुलेशन के लिए फर्स्टली फ्लैक 90 डिग्री एल्बो के फ्लेक्शन में यू हैव टू गिव द traction and the counter traction, and with traction alone displacement ठीक हो जाते हैं. और अगर ठीक नहीं हुए तो you have to manipulate by your hand while giving the traction, and जब वो fix हो जाए you have to fix it by applying the cast. Okay, open reduction internal fixation is popular in स्पेशली इन एडल्ट्स में, क्योंकि एडल्ट्स के अंदर मोस्टली फ्रैक्चर्स आर डिस्प्लेस्ड. एंड इसमें व्हाट यू डू द प्लेटिंग एंड नेलिंग भी कर सकते हैं. बट याद रखना, अपर लिम्ब के अंदर जनरली अपर लिम्ब बोन्स में you prefer plating, whereas in lower limb bones you prefer the nailing. बट लोअर लिम्ब में भी जो आर्टिकुलर सर्फेसिस के पास वाले या इंट्रा आर्टिकुलर फ्रैक्चर्स होते हैं, देयर यू गो फॉर द प्लेटिंग. ओके, नाउ बोथ बोन फोर आर्म्स वेरी इंपॉर्टेंट. अगर ओपन है तो आपको सर्जरी करनी ही करनी है. ओके, इन केस ऑफ ओपन फ्रैक्चर सर्जरी इज इम्पॉर्टेंट. In case of open fracture, surgery is important. And if it is closed and it is both bone fracture, displacement नहीं है तो conservative, displacement है then surgery. And if it is only one bone fracture, so you have to very importantly see the proximal and distal radioulnar joint. अगर radioulnar joint are okay, there is no associated dislocation of that joint, you can go for the conservative treatment by close reduction. But if it is displaced or dislocated the radioulnar joints, you have to go for the surgery. Okay, here you can see in the image. Okay, the images बाद में है. I will show you now. Complication में there can be infection or Volkmann ischemia, delayed or non-union. We have seen ulnar shaft at the junction of middle and distal 1/3 is the most common site. Okay, malunion and cross union. Cross union क्या होता है? जनरली दोनों बोन जब एक साथ फ्रैक्चर होती है तो sometimes there can be cross union between the two bones. So इसको प्रिवेंट करने के लिए ड्यूरिंग सर्जरीज व्हाट वी डू, ड्यूरिंग सर्जरी एक ही इंसिजन से हम दोनों बोन्स में प्लेटिंग नहीं करते हैं. वी गिव अ डिफरेंट इंसिजन फॉर प्लेटिंग ऑफ बोथ द बोन्स. रेडियस के लिए this is your supination side, so in the anterior side में we give the incision for the radius bone. Okay, and ulna के लिए we give incision on the posterior side. Okay, this is your cross union. Okay, what is this? This is your cross union. This is your cross union. Now Monteggia fracture dislocation and Gallagher fracture, very important, and we have discussed it many a time. सबसे पहले Monteggia fracture dislocation को discuss करेंगे. It is MUP, that is proximal 1/3 of the ulna with dislocation of the radius head. आउटस्ट्रेच हैंड पे. फ्लेक्शन एंड एक्सटेंशन टू टाइप का होता है. मोस्ट कॉमन इज द एक्सटेंशन टाइप, जिसमें डिसलोकेशन एंड डिस्प्लेसमेंट दोनों ही एंटीरियर डायरेक्शन में होता है. एंड देयर इज बार्डो सिस्टम classification. So Bardo type 1 is your extension type, and Bardo type 2 is your flexion or posterior type, and it is called as the reverse Monteggia fracture dislocation. It is Bardo type 2. Okay. Now इसमें surgery is required where you fix this by plating. This is Bardo type 1 because anterior है सब जगह, so it is Bardo type 1, and you reduce it, then fix it with the K wire. This is what you do in the surgery or treatment of the Monteggia fracture dislocation. Now Galeazzi fracture dislocation, GRD, it is fracture of the distal 1/3 of the radius with dislocation of the radio-ulnar joint. Okay, and the radius इसमें भी most commonly anteriorly and medially displaced होती है, and इसमें भी the treatment is by surgery, plating and the KY fixation. Here you can see plating of the radius and KY fixation of the radio-ulnar joint. So अब ये radio-ulnar joint dislocated है कैसे पता लगता है? First of all, clinical features, deformity, and also what you will see that normally the radial styloid is above the styloid process of the ulna. Okay, the radial styloid is above the styloid process of the ulna. So this is how you'll diagnose the radio-ulnar joint dislocation. Now we'll come to very important fracture, that is your Cooley's fracture. ओके, पुलीज फ्रैक्चर एंड स्मिथ फ्रैक्चर दोनों एक दूसरे के काउंटर पार्ट है, एंड आपको पुलीज फ्रैक्चर याद रखना है, उसका ऑलमोस्ट ऑपोजिट इज स्मिथ फ्रैक्चर. तो सी के बाद डी आता है. सो पुलीज फ्रैक्चर इज एन distal and radius का fracture at the cortico-cancellous junction just about 2 centimeter from the articular surface, and it is extra articular. ये तो हो गया कॉमन दोनों में. ओके, पुलीज फ्रैक्चर में सी के बाद डी आता, तो द डिस्प्लेस्ड फ्रैगमेंट, द डिस्टल फ्रैगमेंट विल बी टिल्टेड वेयर dorsally, that is posteriorly, due to fall on an outstretched hand, and it is most commonly seen in the elderly women due to osteoporosis. Okay, very important. Normally क्या होता है, the distal articular surface of the radius faces ventrally, that is anteriorly and medially. So normally there is anterior tilt, and the tip of the radial styloid is more upwards than the ulnar styloids, and कितना around 1 centimeter. ये याद रखना. So this is your Cooley's fracture where there is dorsal tilt and it is extra articular at the cortico-cancellous junction. Okay, एंड वेरी इंपॉर्टेंट, सी के बाद डी आता है, तो डी से इन कोलीज फ्रैक्चर देयर इज डिनर फोक डिफॉर्मिटी. ओके, देयर इज dinner fork deformity, very important, like the dinner fork. Here you can see. Okay, and there will be pain when you will flex or rotate your wrist. This is your dinner fork deformity. और इसमें generally it is only of cosmetic value. बाकी if you go for do proper physiotherapy, the pain will subside, and the treatment is generally not required. Okay, dorsal tilt इसकी characteristic होती है, we know it, we have seen it multiple times. So this is your dinner fork deformity. ओके, एंड इसके लिए एक इम्पॉर्टेंट स्पेशल कास्ट आता है, एंड यू हैव टू रिमेम्बर इट, एंड दैट इज योर पोलीस कास्ट. पोलीस कास्ट को कैसे लगाते हैं? इन हैंड शेकिंग पोजीशन में. in hand shaking position में you have will give a sustained traction, then you will जो दोनों फ्रेगमेंट्स है उन दोनों फ्रेगमेंट्स को एक दूसरे से अलग करोगे, यानी डिसइम्पैक्ट करोगे. then you will flex the wrist, okay, you will flex the wrist, palmar flexion, and you will manipulate and reduce the flexion. For disimpact करने के बाद palmar flexion and then ulnar deviation. Okay, so very important is palmar flexion and ulnar deviation. Then you put a below elbow cast. Okay, this is your Cooley's cast. This is your Cooley's cast, like in hand shaking. So pronation, palmar flexion and ulnar deviation. Okay, this is your mechanism of closed manipulation or closed reduction of Cooley's fracture. Okay, now committed fracture agar hai, so you have to go for the surgery, and volar plating is done in the adults, and in elderly you can fix it by a K wire or a external fixator. And distraction के लिए you use an external fixator called as Jess fixator or the radius Jess, which distract the fragment जिससे वो जो periosteum and ligament से they are stretched and keep the commuted fragments in place, and this is called as the ligamentorexis. This is called as the ligamentorexis. So this is your volar plate and this is your distraction के लिए Jess external fixators. Okay, now complications. Most common complication is a stiffness of the finger followed by the malunion. Okay, and malunion may you will have the dinner fork deformity. Okay, other other where what you will have, you can have Sudex osteodystrophy. This is your Sudex osteodystrophy. Okay, in Sudex osteodystrophy what you will have, there will be pain, stiffness, hardness, swelling, and the skin will appear like glossy and stretched when you remove the plaster. Okay, now dinner fork deformity. Dinner fork deformity is a malunited Colles fracture. Okay, now other deformity can be subluxation of the inferior or the distal radioulnar joint, because अगर आपने पुलिस फ्रैक्चर को फिक्स नहीं किया है तो there are chances that it can collapse. Also there will be shortening of the radius. See here, you can see in the image, yes, the image of police fracture. Here you can see, ये जो इसको अब आपको इसी में ही फिक्स करना है. अगर if you will not fix it, then this fragment will get collapsed and there will be shortening of the radius. Understood? So this shortening of the radius will lead to the subluxation or dislocation of the distal radioulnar joint. And इसके में ट्रीटमेंट क्या होता है? जनरली इट रिक्वायर्स नो ट्रीटमेंट, और फिर भी अगर ज़्यादा है तो this is a non-functional bone, distal end of ulna. Okay, which is non-functional bone? Distal end of ulna is non-functional bone. So आप क्या करते हो? उसका excision कर सकते हो, and it is very importantly called as the Derek's resection. Carpal tunnel syndrome भी हो सकता है due to median nerve compression, or Sudex osteodystrophy, or there can be rupture of extensor pollicis longus tendon also. It is very rare. And ये क्यों होता है? If there is loss of blood supply to its tendon or due to friction, there can be rupture of this tendon, and the transfer is by tendon, treatment is by tendon transfer. Okay, not so important. नाउ स्मिथ फ्रैक्चर इज द रिवर्स ऑफ कोलीज. जो सिमिलर बात है वो है कि एक्स्ट्रा आर्टिकुलर होगा, कॉर्टो कैंसिलस जंक्शन, कॉर्टिको कैंसिलस जंक्शन पे होगा. रेस्ट ऑल आर सेम, सॉरी डिफरेंट. और इसमें क्या होगा? देयर विल बी वेंट्रल और एंटीरियर और द वोलर टिल्ट. Okay, and it will be very importantly due to fall on flexed wrist. अगर आउटस्ट्रेच्ड हैंड या आउटस्ट्रेच्ड रिस्ट पे फॉल होगा तो चांसेस आर ऑफ द कोलीज फ्रैक्चर, एंड फ्लेक्स में होगा तो स्मिथ फ्रैक्चर. ओके, and Smith fracture is more dangerous. Now Barton's fracture भी distal and radius का ही fracture होता है, but it is intra-articular and there is associated dislocation of the carpal bones also, and there is associated dislocation of the carpal bones also, and it is of two types. अगर anterior displacement है तो बोला Barton, and the other is of the posterior displacement, and intra-articular है. So treatment is like that only. What the treatment is, क्लोज रिडक्शन ट्राई करते हो, but if there is collapse you have to fix it with the plating, and generally intra-articular है so conservative से ज़्यादा अच्छा रहता है plating. Okay, now a question. A 65-year-old woman falls on an extended and outstretched hand while walking her grandchild to school. She presents to the emergency department in severe pain and holding her left wrist. On examination, there is swelling, tenderness, and deformity, dinner fork pattern. Image of the injury X-ray is shown. The X-ray reveals displacement and angulation of the distal radius. There is no carpal displacement. Which of the following is likely diagnosis? Very, very easy. So the answer will be the Colles fracture. Okay, so the answer will be the Colles fracture. Okay. Now the fracture of this radial styloid is the Schoffer's fracture, which is fracture of the radial styloid, and the posterior most a chip avulsion fracture of the talus is your Shepherd fracture. Okay, this is your Shepherd fracture. Schoffer's fracture is also called as the Hutchinson fracture or the backfire fracture. ओके, शॉफर्स फ्रैक्चर को प्यार से क्या बोलते हैं? हचिंसन फ्रैक्चर और बैकफायर फ्रैक्चर भी बोलते हैं. रेडियल स्टाइलॉइड प्रोसेस का होता है ड्यू टू कंप्रेशन ऑफ द स्केफॉइड बोन अगेंस्ट द स्टाइलॉइड प्रोसेस. ओके, नाउ true about tennis elbow is, okay, true about tennis elbow. So tennis elbow is your lateral epicondylitis, and your golfer's elbow is the medial epicondylitis, and lateral epicondyle is the origin, not insertion, of the common extensors, and there is injury to these tendons, microscopic injury. इसके लिए एक ब्रेस आता है, वो आप यूज कर सकते हैं, and proper physiotherapy. There is pain in extension, and most common extensor tendon that is involved is extensor carpi radialis brevis. Okay, extensor carpi radialis brevis. Okay, so the pain will be on the lateral epicondyle, that is outside of the elbow, and in golfer's elbow it will be on the inside of the elbow. Okay, and you give a brace that is called as the counter force brace, जो इसको compress करता है and rest देता है and pulling of extensor tendons की को prevent करता है ताकि injury और aggravate ना हो. Okay, now next question is Finkelstein test is positive in. So Finkelstein test is positive for dequervin tenosynovitis. Okay, so there are different tests which are important. So सबसे पहले we'll have the see about the test of the carpal tunnel syndrome. Okay, carpal tunnel syndrome में median nerve is affected, तो उसके जो test होते हैं we'll see. So median nerve, if it is affected, it will there will be loss of function of the first, second and third fingers. ओके, ये आपको ध्यान रखना है हमेशा, be it in the hand or be it in the foot, your thumb is your first finger, remember this. So the different tests that I use for the carpal tunnel is your, firstly it is your Phalen's test. As you can see in the image, in Phalen's test you have to just flex the wrist like this for 60 seconds and there will be pain, tingling sensation, numbness in these three fingers. In Tinel test, just tapping over the transverse carpal ligament or the carpal tunnel, you or the flexor retinaculum, you will have these symptoms. Reverse Phelan test would be like this, same. टॉर्निकेट टेस्ट और द गीलियल टेस्ट, आप इसमें क्या करते हो, अपर आर्म पे और आर्म पे यू पुट द टॉर्निकेट विद सिस्टोलिक प्रेशर फॉर 60 seconds and there will be tingling numbness in this area. Okay, now decurvent tenosynovitis के लिए you do the Finkelstein test. In Finkelstein test thumb को wrist के अंदर ऐसे करके you will go for the फ्लेक्शन एंड द रेडियल डिविएशन, और ऐसा करने पे देयर इज पेन, टिंगलिंग सेंसेशन इन योर थंब। ओके, इट इज अ स्टेनोजिंग टीनोसाइनोवाइटिस जिसमें फर्स्ट यानी थंब कंपार्टमेंट और दैट टू द एक्सटेंसर कंपार्टमेंट इज, फर्स्ट एक्सटेंसर कंपार्टमेंट इज इन्वॉल्व्ड। ओके, this is your Finkelstein test. Okay, decurvent synovitis, extensor pollicis brevis is most frequently involved, and अंदर करके ऐसे अगर आप, sorry not radial, ulnar deviation of the wrist करते हो तो there is pain and tingling sensations. These are different types of fractures. I have planned a special X-ray class for you, so I'll cover all these special naam wale fractures in that class, so don't worry. Now next question is identify the test performed. Identify the test performed. Okay, so this is your Allen's test. Okay, this is your Allen's test, very important. This is your answer is your Allen's test. Okay, Allen's test is used before cardiothoracic surgery and it determines the potency of the radial and the ulnar artery. Okay, distally दोनों arteries को block करते हो firstly and then you release it one by one and you see the return of the color and the capillary refill time. And normally capillary refill time, it is important, ये important है कि capillary refill time normally is less than 5 seconds. Okay, now we'll come to the wrist bone, that is the carpal bones, and इससे पहले let's take a break of 1 minute का break लेते हैं। चलिए, let's take a break of 1 minute. I hope समझ आ रहा होगा आप लोगों को। Okay, let's take a break of 1 minute. Now let's start again. Okay, so we will be starting about the wrist bones. Okay, so wrist bone जो carpal bones होती है, they are very sometimes very confusing to remember. So उसकी सब जनों ने trick बना रखी है. Okay, so let's revise that trick also, and it is if you go from the lateral to medial side, that is from the radius to the ulna, and two groups of four में you divide करो, first proximal then the distal. So you just remember some lovers try positions that they can't handle. Okay, so as for here will be scaphoid, lunate, triquetral, pisiform, try positions that they. अब यहाँ पे दो टी आएंगे, can't handle, capitate, and H for hamate. नाउ टी फॉर ट्राइक्यूट्रल तो पहले हो गया, अब ट्रेपेजॉइड और ट्रेपेजियम दो आते हैं, तो याद रखो जेड आई और जेड ओ, ट्रेपेजियम एंड ट्रेपेजॉइड. ओके, सो इसमें जेड के बाद आई पहले आता है अल्फाबेटिकली, देन ओ आता है, तो रिमेंबर ट्रेपेजियम पहले देन दी trapezoid. Okay, remember this, यही पे confuse होते हैं. So these are your carpal bones. Okay, here you can see in the x-ray also, and most common and the most important carpal bone fracture is your scaphoid fracture, and it is more common in the young adults age group. Okay, and most commonly the fracture is in the waist, that is the junction of the proximal and within medial 1/3, and इसमें एक बहुत important complication होता है, that is your avascular necrosis, very important, and it is most common in the proximal 1/3 or the pole of the part. So this of the scaphoid, so this is your watershed area. So this is your watershed area. Now diagnosis, there will be pain, swelling over the radial aspect of the wrist, especially in the anatomical snuff box. Okay, especially in the anatomical snuff box, and these x-rays are difficult to identify, so you have to do the serial x-rays again and again. And after 1 week, like in many cases, after 1 week of the trauma, when the swelling subsides and avian sets in the initial days, then you see a clear cut fracture line. So anatomical snuff box, so anatomical snuff box, here you can see there is a depression here. This is your anatomical snuff box, and इसके आपको बॉर्डर्स याद करना इम्पॉर्टेंट है. द मीडियल बॉर्डर इज बाय द एक्सटेंसर pollicis longus, and the lateral border is by the extensor pollicis brevis and the abductor pollicis longus. Okay, and proximally styloid process of radius होगा, and at the floor there will be carpal bones. Okay, content is very important. Content is radial artery, superficial branch of the radial nerve, and the cephalic vein. Okay, this is your anatomical snuff box, very important. Okay, now scaphoid cast, police cast था वैसे ही scaphoid cast होता है, बस it is also called as the glass holding cast. and इसमें क्या होता है, the thumb is also covered. वहाँ पे the slab was just, or the cast was just till the heads of the 5 metacarpals, but here उसके साथ में इस direction में you will have the cast covering the thumb also, and the Colles cast was in the ulnar deviation, it is in the radial deviation with palmar flexion. सॉरी, palmar flexion उसमें लेकिन उसमें था palmar flexion, इसमें there will be dorsiflexion, a little dorsiflexion. Okay, and Generally surgery is required because there is non-union malunion, so the surgery is done by the compression screw to reduce the fracture side, and it is open reduction internal fixation by the Herbert screw. So undisplaced है, try for the cast पहले, अगर नॉन यूनियन में जाता है या फिर एवियन हो जाता है, स्टार्ट होने लगता है, या फिर डिस्प्लेसमेंट इज वेरी मच, देन यू गो फॉर द surgery. Radiological features we have discussed, and one important cheese is the scaphoid is viewed most appropriately in an oblique view. So if you have suspected scaphoid fracture, then go for the oblique view with the AP and the lateral view. Okay, and initially it might not be visible. After 1 or 2 weeks, agar if you repeat karwate ho check x-rays, there you can visualize it more easily. Conservative hota hai, treatment we have discussed. Okay, now avian is very common here, and so most common and the most important complication is avascular necrosis, and if it sets in, there is no other way to just excise the scaphoid. Okay, and there is a very precarious blood supply through the waist. तो फ्रैक्चर साइट होती है, एंड प्रॉक्सिमल इज योर दिस. सो प्रॉक्सिमल is the most common site of avian, and also proximal 1/3 is the most common site of non-union also. Okay, most common site of the non-union also. It is very difficult to treat. अगर symptomatic है, then the avascular necrosis का excision करना ज़रूरी होता है. Okay, now delayed and non-union, it is also common. Okay, and the most common cause of delayed or non-union in any type of fracture is your improper immobilization. It is a potential question. Okay, the reason is improper immobilization. ठीक है, and in non-union you will have the distinct features of rounding of the fractures. They are not sharply defined. Okay, so the treatment we have already discussed, Anna. So firstly we will try to fix it by the surgical, like Herbert screw, grafting, etc. Okay, and if the avian has set in, you have to excise it. Wrist osteoarthritis is very common. Okay, here you can see arthritic changes, osteophytes and decreased joint space, etc. Now lunate dislocations. Lunate dislocations, आपको ये चीज समझनी है. See, lunate dislocations. This is your radius. This is your lunate, and this is your capitate. This is your normal. Normally they are like this. In lunate dislocation, this is your lunate dislocation, where only lunate is dislocated. These two are in the straight line, and this is your, sorry, not this. This is your, so these both are dislocated, so this is your perilunate dislocation. Okay, lunate में बाकी सब normal anatomical position पे होंगे. Only lunate will be dislocated. In perilunate, the lunate will be that in normal anatomical position, but the capitate will be dislocated. And most commonly the dislocation is anteriorly. Okay, and perilunate dislocation is treated, and the lunate dislocation is have to be treated by the open reduction. Okay, and there is a specific sign called as the Terry Thomas sign, where there is this space between the lunate and the scaphoid. This is called as the Terry Thomas sign, and this scaphoid will show the signet ring sign like this. ओके, नाउ बॉक्सर्स फ्रैक्चर, बॉक्सर्स फ्रैक्चर क्या होगा, फिफ्थ मेटाकार्पल का नेक फ्रैक्चर होता है which is displaced anteriorly or ventrally, usually in the boxers. What is mallet finger? Mallet finger like this, यानी extension नहीं कर पा रही है, तो there is avulsion injury or the injury of the extensor tendon at the DIP joint, and इसका उल्टा is the jersey finger. In jersey finger, what you will see, there will be injury to the flexor tendon at the DIP, that too avulsion injury of the flexor digitorum profundus. It will be unable to flex it. This is your jersey finger. Trigger finger, we have discussed कि metacarpophalangeal joint में क्या होता है. At the metacarpophalangeal joint, at the anterior side, there is a pulley system and there is a fibrous sheet, and sometimes वहाँ पे क्या होता है, जो टनल हो जाती है, थिक हो जाती है ड्यू टू अ नोड्यूल इन द टेंडन, सो यू विल हैव अ ट्रिगर फिंगर. इनिशियली ऐसे लॉक हो जाती है बट यू कैन मैनिपुलेट इट, बट इन further cases, in chronic cases or last stage cases, you will not be able to manipulate it, then you will have to go for the surgery. Okay, now this, what is this, this is nothing but your jammed finger. Okay, jammed finger जो होती है, this is just after the injury, it is your jammed finger. Claw hand is of two types, partial and complete. Partial claw hand is जब only and only ulnar nerve palsy होती है. Okay, and complete claw hand will be if there is ulnar plus median nerve palsy, then you will have the complete claw hand. Okay, so Dupuytren's contracture, ये सब चीजें I'll cover in, I have a special session on image based question before examination, so all these special things I will cover in that session. Okay, so golfer's elbow, we have discussed medial epicondylitis होता है. Very important, skier's thumb or the gamekeeper's thumb, it is the avulsion or injury to the ulnar collateral ligament due to forced abduction. Ulnar collateral ligament due to forced abduction at the first metacarpophalangeal joint. Okay, pitcher's elbow जो होता है, that also is the medial epicondylitis. याद रखना. So golfer's elbow and pitcher's elbow is the medial epicondylitis, and tennis elbow is your lateral epicondylitis. Okay, Salter Harris classification we have read. इसमें एक type 6 भी होता है Salter Harris, which is called as the Rangs type, and there is a pericondyal ring around the growth plate. This is your sixth type or the Rangs type, which is identify the mark structure. ये कौन सा structure है? Very easy. It is your lunate. Okay, it is your lunate. The mark structure here is your lunate. This is some lovers try positions that they can't handle. Okay, now transverse carpal ligament is flexor retinaculum of the hand or the anterior annular ligament on the palmar side पे होता है. Okay, very important. Now Bennett fracture dislocation, it is first metacarpal. Very important. Bennett fracture dislocation is intra-articular. Bennett fracture dislocation is the intra-articular fracture of the carpo. Here you can see at the carpo-metacarpal junction. Okay, carpo-metacarpal junction के अंदर there is intra-articular fracture. Okay, so it is an oblique intra-articular fracture at the base of the first carpal with dislocation or subluxation of the metacarpal. Okay, so close manipulation POP अगर mild displacement है, नहीं तो you go for the surgery. Now Rolando fracture is also carpo metacarpal junction. First का fracture होता है, but it is two part fracture and it is extra articular. Okay, remember. स्कायस गेमकीपर थंब में कार्पो मेटाकार्पल नहीं, मेटाकार्पो फेरेंजियल जॉइंट पे होगा, यहाँ पे, नॉट यहाँ पे. ओके, so most commonly fractured carpal bone is scaphoid bone, we have discussed it. Tenderness in anatomical snuff box, scaphoid bone. Finkelstein test, decubital tenosynovitis, we have discussed it right now only. Okay, now we'll come to the peripheral nerve injuries. So peripheral nerve injuries में of the upper limb, very important. upper limb का nerves are very very important. एक क्वेश्चन तो आपके आएगा ही आएगा, भले आप उसको एनाटॉमी में काउंट कर लो या ऑर्थोपेडिक्स में काउंट कर लो और मेडिसिन में काउंट कर लो, but one question from this topic is almost a surety. Okay, now nerves जो होती है, nerves में the axons is covered by the myelin sheet, the peripheral nerves. So each nerve is covered by a sheet called as the endoneurium, and many these nerves form a fasciculi which is covered with the perineurium, and बहुत सारे ऐसे fasciculi along with the artery and the vein, they form a nerve sheet which is covered by the epineurium. Okay, ये चीज आपको बस इतना बेसिक, you need to know about these basics. Okay, now the peripheral nerves जो होती है, these peripheral nerves arise from the spinal cord. There are 31 pairs and these are mixed nerves, means motor and sensory दोनों ही होती है. Now motor innervation is important to test the nerve and sensory innervation is also important to test the nerve. Okay, now there is two things. First is the nerve degeneration and second is the nerve regeneration. सबसे पहले nerve degeneration, कोई भी इंजरी होने के बाद nerve के degeneration होता है, and it is of two types, primary and the secondary. The primary is in the retrograde direction, यानी दी प्रॉक्सिमल पार्ट, इंजरी का जो प्रॉक्सिमल पार्ट होता है वो सबसे पहले डिजनरेट होता है टुवर्ड्स द रेट्रोग्रेड डायरेक्शन. सी, इफ दिस इज योर cell body, this is your axon, this is your dendrite, and the injury is somewhere here. So and this is your proximal, ऐसे जा रहा है पूरा सब कुछ. So this is your proximal part. So in the retrograde direction it will be primary degeneration starting from here, and यहाँ पे the secondary degeneration will be started, which is very importantly called as the Wallerian degeneration. It is very importantly called as the Wallerian degeneration. Now nerve regeneration, रीजनरेशन होता है, इस डायरेक्शन में रीजनरेशन हुआ. सो फ्रॉम द प्रॉक्सिमल सेगमेंट distally the axonal stump will begin to grow from the proximal to the distal fragment. So if there is Schwann cells or the myelin sheet, वो आगे 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 the axonal sprout will go and there will be the formation of the long nerve. But if the endoneurial tube is interrupted, यानी पूरा कट है, so the axonal stump will not be able to migrate and it will form the end neuroma or neuroma. Here you can see this is the end neuroma, and here it is continuous, so in continuously the injured segment पे there is new nerve formation. Okay, so very important एक चीज है कि the rate of recovery of axon is 1 mm per day. Okay, and the muscles which are nearest to the site of the injury will recover faster, and then it will travel like into the periphery centrifugally, and this is called as the motor march. And this is called as the motor march, very important. Okay, now classification जो है, classification of the nerve injuries में you have two classification. First is the Seddon's classification and second is the Sunderland classification. तो Seddon classification में for neuropraxia, axonatomesis and neuratomesis, and Sunderland classification type 1, type 2, 3, 4 and type 5. सो एक्सोनोटोमेसिस में को 3 पार्ट्स में डिवाइड कर दिया है सुंदरलैंड ने, कि सिर्फ एक्सॉन हुआ है या फिर एक्सॉन के साथ में एंडोन्यूरियम भी है, एक्सॉन एंडोन्यूरियम और पेरिन्यूरियम है तो टाइप 4 हो जाता है, एंड टाइप 5 तो कंप्लीट. सो वी ऑल नो अबाउट दिस कि न्यूरोप्रैक्सिया में देयर इज ओनली फिजियोलॉजिकल डिसरप्शन ऑफ कंडक्शन, कोई स्ट्रक्चरल इंजरी चेंज नहीं होती है. सो देयर इज 100% स्पॉन्टेनियस रिकवरी. एक्सोनोटोमेसिस में एक्सॉन्स आर डैमेज बट the internal architecture is preserved, so Wallerian degeneration is present. Spontaneous हो जाती है but it may take months and it is not complete. Neuratomesis में the entire nerve is damaged, so there is no spontaneous degeneration, so surgery is required and it has the worst prognosis. Okay, सब सबसे पहले अपन आते हैं रेडियल नर्व पे, एंड इट इज द मोस्ट इम्पॉर्टेंट नर्व फॉर द एग्जामिनेशन पॉइंट ऑफ व्यू. ओके, सो द रूट वैल्यू ऑफ द रेडियल नर्व इज C5678T1. इट इज अ ब्रांच ऑफ, देखो रेडियल नर्व आते ही आपको एक चीज दिमाग में आनी चाहिए, दैट इज पोस्टीरियर. ओके, एक चीज आपको जो दिमाग में आ जानी चाहिए, दैट इज अ पोस्टीरियर, and I'll tell you why. Firstly, posterior cord of the brachial plexus से निकलती है, and in axilla, okay, in axilla firstly it will give a branch to the long head of the triceps, then it will enter the arm, and in arm firstly it will give a cutaneous branch, posterior cutaneous nerve of the branch, and इस बार किसको पहले दी थी, लॉन्ग हेड ऑफ द ट्राइसेप्स को एक्सिला के अंदर. आर्म के अंदर ये क्यूटेनियस ब्रांच देगी और मीडियल हेड ऑफ द ट्राइसेप्स को देगी. नाउ पोस्टीरियरली टू ह्यूमरस पे, रेडियल ग्रूव से पोस्टीरियर सरफेस ऑफ द ह्यूमरस पे आएगी, एंड wind round करके it will give branches to the lateral head of the triceps and coneus muscles and the cutaneous branches, and will pierce the lateral intermuscular septum at the junction of middle and the distal 1/3, and in the distal 1/3 of the arm it will lie एंटीरियरली. तो पोस्टीरियर ऑफ द ह्यूमरस के ग्रूव से वाइंड राउंड होके एंटीरियरली आ जाती है नियर द एल्बो, इन द एंटीरियर कंपार्टमेंट बिटवीन ब्रेकियालिस एंड ब्रेकियोरेडियालिस. ओके, एंड इन द एल्बो इन फ्रंट ऑफ द लेटरल कॉन्डाइल. याद रखना, लेटरल कॉन्डाइल के फ्रंट में, इन फ्रंट ऑफ द लेटरल कॉन्डाइल इट डिवाइड्स इनटू 2 branches, superficial and the deep. Deep branch is your motor branch and superficial branch is your sensory branch which travels along the radial artery. Okay, and the deep branch will supply the extensor carpi radialis brevis and the supinator muscles. Okay, extensor carpi radialis brevis and the supinator muscles, then it will pierce the supinator and it will become the posterior introitious nerve of the forearm in the posterior compartment, and it will supply all the extensor muscles. So याद रखना है कि रेडियल नर्व पोस्टीरियर कंपार्टमेंट को सप्लाई करती है, पोस्टीरियर कॉर्ड की ब्रांच होती है, पोस्टीरियर कंपार्टमेंट में क्या होते हैं, एक्सटेंसर्स होते हैं, एंड आर्म में भी पोस्टीरियर मसल दैट इज ट्राइसेप्स के तीनों हेड्स को सप्लाई करती है. वेरी इंपॉर्टेंट अबाउट द रेडियल नर्व. हियर यू कैन सी इन द डायग्राम. okay, here you can very easily appreciate in the diagram that spiral groove से anteriorly आ गई in front of the lateral condyle. Here it gives two branches, superficial and the deep branch or the posterior interosseous nerve, है ना. तो रेडियल नर्व है इसलिए उसकी ब्रांच क्या होगी, पोस्टीरियर इंट्रोशियस नर्व होगी. दैट्स व्हाई आई वाज टेलिंग कि याद रखना है रेडियल आते ही आपके दिमाग में क्या आना चाहिए, पोस्टीरियर. ओके, नाउ वील डिस्कस अबाउट द टेस्ट. तो ये सब नर्व्स पे एप्लीकेबल है. हाई नर्व पाल्सी, लो नर्व पाल्सी. तो हाई रेडियल नर्व पाल्सी क्या होगा, इफ द नर्व इज इंजर्ड अबव द एल्बो, दैट इज इन द रेडियल ग्रूव. सो उसमें क्या होगा, ऑल द मसल्स supplied by the radial nerve, nerve supply will be cut off. There will be loss of motor and sensory function except the anconeus and the medial and long head of the triceps. Okay, and उससे भी ऊपर अगर हो गई, so only the long head of triceps will work, rest all will be paralyzed. It is called very high radial nerve palsy. And low radial nerve palsy में around the elbow or below the elbow, so there will be failure of the extension, all the extensor muscles of the posterior compartment and the supinators will be paralyzed, leading to the wrist drop. Okay, सो लो रेडियल नर्व पाल्सी में कौन कौन सी नर्व्स मसल्स बच जाएगी, द ब्रेकियो रेडियालिस, एक्सटेंसर रेडियालिस, कार्पाई रेडियालिस एंड लॉन्गस विल बी लेफ्ट. ओके, नाउ प्रॉक्सिमल टू डिस्टल चले तो फॉलोइंग मसल्स विच आर सप्लाइड बाय द रेडियल नर्व्स इज एग्जामिन. फर्स्टली ट्राइसेप्स. तो ट्राइसेप्स को कैसे एग्जामिन करेंगे, ट्राइसेप्स का काम होता है एल्बो का एक्सटेंशन. सो अगेंस्ट द रेजिस्टेंस यू विल आस्क द पेशेंट टू एक्सटेंड द एल्बो and you can feel the triceps contraction. Brachioradialis, if you will ask the patient to flex the elbow for 90 degrees in prone position of the forearm, it is done by the brachioradialis, but you will not be able to do this in case of radial nerve palsy. This is the triceps where you will try to extend the elbow, and if it is normal you can feel the contractions of the triceps, and here with flexion and pronation you can feel the contraction of the brachioradialis muscle. Okay, now second are the wrist extensors, and वो नहीं हो पाएगा तो there will be wrist drop. ठीक है, and extensor digitorum. So extensor digitorum में there will be finger drop, but this will be at the level of metacarpophalangeal joint, not at the interphalangeal joint. So finger drop भी होगा due to extensor digitorum tendon, but these are at the level of metacarpophalangeal joints. Okay, because the finger का जो extension होता है at the interphalangeal joint, it is by the lumbricals. And extensor pollicis longus का क्या काम होता है, the extensor pollicis longus does the pollicis यानी thumb. तो thumb के अंदर interphalangeal joint का extension करते हैं. Okay, so it is the extensor pollicis longus. ओके, तो रेडियल नर्व इंजरी जो होती है उसको डिफरेंट नेम से भी जाना जाता है. फर्स्टली बहुत ज़्यादा पी के ऐसे, इफ़ यू आर स्लीपिंग होल नाइट भंड, ओके, सो इट इज़ योर कॉल्ड सैटरडे नाइट पाल्सी, हनीमून पाल्सी, जब आपके स्लीपिंग ऑन योर पार्टनर्स आर्म, द हैंडकफ न्यूरोपैथी, टाइट फिटिंग हैंडकफ से, क्रच पैरालिसिस, क्रच लेके जो चलते हैं, ओके, बैसाखी, स्क्वैश पैल्सी इन स्क्वैश प्लेयर्स. ओके, हियर इज योर रेडियल नर्व स्प्लिंट. ओके, रेडियल नर्व, दिस इज योर डायनामिक स्प्लिंट. रेडियल नर्व के लिए यू डू, और फॉर द रिस्ट ड्रॉप यू गो फॉर दीज स्प्लिंट्स. ओके, नाउ वेरी इंपॉर्टेंट इज योर क्यूटेनियस और सेंसरी ब्लड सप्लाई ऑफ द अपर लिम्ब। तो सबसे पहले अपन बात करते हैं किसकी, हैंड की। ओके, फर्स्टली वील टॉक अबाउट द हैंड। तो हैंड में सबसे पहले एंटीरियर में, सो हैंड में सबसे पहले एंटीरियर में वील सी की 2 fingers or 1.5 fingers. 1.5 fingers will be supplied by the ulnar nerve, and rest 3.5 fingers on the anterior by the median nerve. And posteriorly अगर आप देखोगे तो 1.5 fingers of the posterior by the ulnar nerve, and the 3.5 fingers of the posterior by the radial nerve. Okay, तो अल्नर नर्व तो मीडियल को पकड़ लिया। अब लेटरल 3.5 fingers में एंटीरियरली बाय द मीडियन नर्व, पोस्टीरियरली बाय द रेडियल नर्व। बस पोस्टीरियरली में भी द टिप्स विल बी बाय द मीडियन नर्व। सो इसके अंदर द एरिया दैट इज ग्रीन इज योर अल्नर नर्व, द एरिया दैट इज योर ब्लू is the blue area is your median nerve, and your red or pink area is your radial nerve. Okay, remember this. ये ही आपके ज्यादातर काम का एक्सिलरी नर्व तो डेल्टॉइड पे, रेजिमेंटल बैच एरिया वाले पे, देन द रेडियल नर्व। ओके, देन एंटीरियरली यू विल हैव लेटरल साइड में रेडियल नर्व, एंड in the forearm you will have the musculocutaneous nerve. Okay, now this was about the radial nerve. Now we'll come to the median nerve. Median nerve की root value is C6, 7, 8 and T1, and it is a branch of the lateral and the medial cords, and in the arm it descends with the brachial artery. Okay, it descends with the brachial artery, and it is between the two heads of the pronator teres. ठीक है, फोर आर्म में it is between the two heads of the pronator teres. Okay, and at the wrist it becomes superficial. प्रोनेटर टेरेस के दो हेड्स के बीच में होता है फोर आर्म में जब वो एंटर करता है। इन द फोर आर्म इट इज बिटवीन flexor digitorum superficialis and profundus, and at the wrist it becomes superficial where it lies between flexor digitorum superficialis and flexor carpi radialis. In the hand it is deep to the flexor retinaculum, enters the palm, and very important, median nerve will supply the muscles of the thenar eminence. Very important, median muscles will supply the muscles of the thenar eminence, and इसमें 3 muscles होती है। First is the abductor pollicis brevis, opponens pollicis and the flexor pollicis brevis. Okay, opponens pollicis, abductor pollicis brevis and the flexor pollicis brevis. Opponens, abductor pollicis brevis and the flexor pollicis brevis. Okay, and also it gives motor branch to first and second lumbricals. First and second lumbricals, very important, first and second lumbricals, and to the flexor or the anterior compartment को भी sorry, it supplies the flexor or the anterior compartment, except medial half of the flexor digitorum profundus and flexor carpi ulnaris, and both of these are supplied by the ulnar nerve. तो ये ध्यान रखना, अल्नर मीडियल साइड होती है तो फ्लेक्सर डिजिटोरम प्रोफंडस का मीडियल कंपार्टमेंट हो गया, प्लस अब फ्लेक्सर कार्पे अल्नारिस में ही अल्ना आ रहा है तो बोलता है कि यस अल्नर नर्व ही इसको सप्लाई करेगी। Okay, so very important. And the pronators, so supinators and extensor muscles by the radial nerve, pronators, flexors except these two, the thenar eminence की muscles and the first two lumbricals first finger है तो this is your 4 lumbricals, 1 2 3 and 4. These are your 4 lumbricals, 1 2 3 and 4. The first two lumbricals are also supplied by the मीडियन नर्व। ओके, सो मीडियन नर्व का सप्लाई अपन ने देख लिया, इसको सप्लाई करती है। नाउ टेस्ट, दो ही तरह की पाल्सीज होती है, हाई मीडियन नर्व पाल्सी प्रॉक्सिमल और अबव द एल्बो, एंड लो मीडियन नर्व पाल्सी बिलो द एल्बो। ओके, नाउ tests of the muscles. Firstly, flexor pollicis longus. So flexor pollicis longus, it will supply the thumb. It will supply the thumb. So it will ask to flex the terminal phalanx of the thumb against resistance. Now flexor digitorum superficialis and the lateral part of the flexor digitorum profundus. So इसमें you have the pointing index or the Ochsner's index, because you will not be able to clasp your index finger, so flex नहीं हो पाएगी. So this is your पॉइंटिंग इंडेक्स. अब आप बोलोगे कि सर ये वाली क्यों, ये वाली इसलिए क्योंकि these आर फ्लेक्स्ड बाय द medial half of the flexor digitorum profundus. Now flexor carpi radialis, जैसे अपन ने पढ़ा था एक्सटेंसर कार्पाई रेडियालिस में, ओके, उसी की तरह फ्लेक्सर कार्पाई रेडियालिस में क्या होगा, द रिस्ट विल not be able to flex. Okay, so it will be in the extension, so there will be wrist deviation to the ulnar side. Okay, the wrist will be deviated to the ulnar side while palmar flexion. जब palmar flexion कराने की कोशिश करोगे, so the wrist will deviate to the ulnar side. Very important, to the flexor carpi radialis. Okay, flexor carpi radialis, FCR. Okay, now muscles of the thenar eminence. Thenar eminence में तीन muscles है, opponens pollicis, abductor pollicis brevis and the, and एक और कौन सी है, एक और है आपके this फ्लेक्सर पॉलिसिस ब्रेविस. ओके, सो इसमें से सिर्फ दो ही आप टेस्ट कर सकते हो, दैट इज अबडक्टर पॉलिसिस ब्रेविस एंड द ओपोनेंस पॉलिसिस. सो अबडक्टर पॉलिसिस ब्रेविस को आप कैसे करते हो, अबडक्टर पॉलिसिस ब्रेविस इज this is your abduction. So you put a pan here. Okay, you put a pan here, and normally you will able to abduct the hand like this. Okay, you will be able to abduct the hand like this. So this is called as the pen test. Okay, to touch with, this is called for testing the abductor pollicis brevis. abduction ऐसे टेस्ट करते हैं, and opponents is this. ठीक है, सिर्फ टिप टिप को टच करना is your opponents test. Ochsner's और clasping index we have also already discussed. flexor carpi radialis के टेस्टिंग में if you do palmar deviation वो ulnar side में deviate हो जाएगा. abductor pollicis के लिए you have the pen test we have discussed. okay, now मीडियन नर्व में यू हैव दी एप थंब. एप थंब में क्या होता है, देयर इज थिनार एमिनेंस की मसल की वास्टिंग होती है. सो देयर इज दिस ape thumb like this is your ape thumb seen in median nerve damage, and also there is benediction hand like this, because flexion of these two fingers will not be possible in case of median nerve injury. So benediction hand होता है क्रिश्चियंस के अंदर. so this is your benediction hand. so pen test हो गया, Ochsner's clasping index हो गया. okay, your benediction hand, ape thumb और ठीक है, these are your special test and different median nerve palsies. now ulnar nerve palsy में C8 to T1 is your root value, and medial side है तो it is on the medial cord and it runs alongside medial to the axillary artery. okay, it pierces the medial intermuscular septum और medial condyle के नीचे से जाती है. okay, it becomes it lies behind the medial epicondyle on the medial side it lies behind the epicondyle, and जैसे जैसे elbow में जाती है it becomes more and more superficial. Okay, and it supplies two flexor muscles, that is flexor carpi ulnaris and medial half of the flexor carpi radialis, sorry, flexor digitorum profundus, medial part or medial head of the flexor digitorum profundus. Okay, wrist में these are the ulnar nerve जो होती है ये flexor retinaculum के superficially जाती है, just lateral to the pisiform bone, remember ये superficially जाती है. Okay, so the ulnar nerve will supply the third and the fourth lumbricals, और lumbricals के function याद करने के लिए you just need to have this, that is pad. Pad is इंट्रोशियाई के दो टाइप की इंट्रोशियाई मसल्स होती है, पामर इंट्रोशिया एंड दी palm at dorsal introssia. Okay, so the palmar introssia pad they will do the adduction like this, whereas the dorsal introssia will do the abduction dab. Okay, so the introssia muscles, third and fourth lumbricals and these two flexors are supplied by the अल्नर नर्व. अल्नर नर्व भी दो टाइप की पाल्सीज होगी, हाई एंड लो. नाउ फ्लेक्सर कार्पाई अल्नारिस लाइक फ्लेक्सर कार्पाई रेडियलिस. फ्लेक्सर कार्पाई अल्नारिस को कैसे टेस्ट करोगे? व्हेन यू डू द palmar flexion and if there is paralysis of flexor carpi ulnaris there will be radial deviation. Okay, there will be radial deviation. Now abductor digiti minimi asked to abduct the little finger against by keeping hand flat on the table. Okay, this is your abductor, see like this on the table, abductor digiti minimi. Introssia, palmar introssia adduction करती है तो there is card test. Generally you will be able to hold the card, but in case of ulnar nerve palsy palmar introssia will not work and you will not be able to hold the card. So this is called as card test for palmar introssia. And dorsal introssia, that is abductors, uske liye you have the Igawa test. And what you do in the Igawa test? In the Igawa test table pe the patient is asked to keep the hand like this and move the fingers sideways. Okay, but he will not be able to do this in case of the ulnar nerve injury. So this is your Igawa test of the middle finger. Okay, now lumbricals में क्या होगा? Lumbricals का action होता है, the action of lumbricals is flexion of the interphalangeal joints. बट इसमें क्या होता है? आइसोलेटेड एक्शंस कैन नॉट बी टेस्टेड. तो वेरी इंपॉर्टेंट कि लम्ब्राइकल्स के लिए आइसोलेटेड टेस्ट नहीं होते हैं. नाउ अडक्टर पॉलिसिस, जनरली क्या होता है? अडक्टर पॉलिसिस इज सप्लाइड बाय द अल्नर नर्व. व्हाट you do is ulnar nerve में you have this Froment sign or the book test. इसमें क्या होता है? सिंपल लैंग्वेज में आप जल्दी से समझें तो what you do generally if you there is, आप किसी को बुक देते हो या कोई भी कार्ड देते हो तो there is adductor pollicis को चेक करने के लिए they will hold like this. Okay, they will hold like this, but there will in case of ulnar nerve palsy flexion नहीं हो पाएगा. ओके, नॉर्मली flexion नहीं हो पाएगा. so there will be like this, you will hold like this एकदम straight. so this is your Froment sign. Okay, the adductor pollicis will be paralyzed and patient will hold the book by using the flexor pollicis longus that is supplied by the median nerve. Okay, this is your Froment sign or the book sign. टाइप्स ऑफ क्लॉ हैंड देख लिया था अपन ने. क्लॉ हैंड में क्या होगा? ओनली 2 digits, आइसोलेटेड अल्नर नर्व, पार्शियल all entire hand, complete claw hand with ulnar and radial nerve दोनों. So ulnar claw hand and benediction hand of benediction में क्या differentiation होता है? It is a confusing thing. So hand of benediction is due to median nerve palsy, whereas ulnar claw hand is due to the ulnar nerve palsy. It is a partial claw hand. Okay. So affected are the little and the ring finger, and it is the middle and the index finger. Little and the ring finger in ulnar and hand of benediction median में it will be the middle and the index fingers. Okay, and muscles paralyzed is the medial two lumbricals, and here the muscles paralyzed is the middle two lumbricals or the first and the second lumbricals. Okay, remember. Now और छोटी छोटी nerves है that we should know, and these are, first there is accessory nerve. Accessory nerves supplies the, okay, so this accessory nerve supplies the trapezius muscle, very important. And trapezius का काम क्या होता है? एक तो overhead abduction करना and to elevate the shoulder. तो अगर आप elevate करने को बोलोगे then you will not be able to do this against the resistance. This is your trapezius muscle accessory nerve. Long thoracic nerve or long thoracic nerve of Bell C5, C6, C7 होता है, and it supplies to very important muscle serratus anterior. And if you put pressure on the wall like this, there will be winging of the scapula on the affected side. की medial border of the scapula will become prominent. In case of its injury, it is called as winging of the scapula. Here you can see medial border is prominent. Boxer's punch test is also used for this. Now the axillary nerve. Axillary nerve is also a branch of the posterior cord of the brachial plexus, and ये कहाँ पे होती है? Surgical neck of the humerus के around wind round होती है axillary nerve. Okay, and it supplies the capsule and the deltoid muscle. Okay, anterior and posterior दो branches होती है. The anterior branches is at the surgical neck of the humerus and the deltoid, and the posterior branch supplies the posterior part of the deltoid and the teres minor. Okay, so this is your axillary nerve. So motor functions, the first 15 degrees abduction नहीं हो पाएगा, and there will be loss of sensations, tingling, numbness in the regimental badge area. Now signs of regeneration of a nerve जो होते हैं, there are certain signs. एक तो motor march we have already discussed. Electrodiagnostic science में we do two types of tests. Nerves के लिए nerve conduction study and the electromyography. Now important is Tinel sign. Tinel sign में क्या होता है? On gently tapping the nerve along its course from the distal to the proximal, इसमें क्या होता है? जैसे जैसे nerve generation होगा वैसे वैसे you will begin to feel sensations or tingling or numbness when you will tap this, and this will occur when you will go from distal to proximal, क्योंकि proximal से regeneration start होगा. Okay, so this is called your Tinel sign. Okay, treatment, major treatment, क्योंकि majority are neuropraxia in case of bone injuries. Okay, so most common it is neuropraxia, so treatment is conservatively, and physiotherapy is very important. Physiotherapy and proper splints or braces is very important. Okay, you remember this is an aeroplane splint for axillary nerve. Axillary nerve के लिए this is an aeroplane splint, or the brachial plexus injury के लिए भी you can use it. This is your radial nerve के लिए cock-up splint. Ulnar nerve के लिए that is your knuckle bender splint for the lumbricals. Physiotherapy, nerve repair में operative management, there are two types of repair, primary and secondary. So primary क्या होता है? If it is not infected Okay, so if it is cut by sharp object and patient reports early, it is called as primary repair. And if it is infected, so pehle after decontamination or debridement, if you do it, it is called as the delayed primary or secondary. Delayed primary word is better, and proper secondary are sometime after the injury, like neglected cases, or there is irritation के complaint लेके आए patients after many years of surgery. Nerve grafting, when the nerve gap is more than 10 centimeter, then only you do the grafting. And most common nerve which is taken is the sural nerve, remember, of the lower limb, and it is an expandable nerve. Remember, sural nerve is an expandable nerve. Okay, now अब ये क्या क्या है, we have discussed all these things. I think you should know this by this time, and it is very important also. Okay, सबसे पहले this is wrist drop due to radial nerve palsy. Okay, this is wrist drop due to radial nerve palsy. इसमें lateral two fingers हो रही है, तो this is ulnar nerve, and उसकी वजह से क्या है, ulnar claw hand or partial claw hand. And this is your ape thumb. Okay, this is your ape thumb, this is your pointing index. Okay, and this is your hand of benediction. All these are due to median nerve palsy. Okay, remember, so ये था अपना nerves, very very important. These nerves are very very important for your examination point of view. So please 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 इनको याद रखना है, इनको at least revise करके जाना है. Okay, these are very important. Now we'll come to CTEV, another very important topic. So we'll take again a break of 1 minute, then we'll come to the last session जहाँ पे we will study about the CTEV and the pediatric orthopedics. Okay, CTEV and pediatric orthopedics अपन पढ़ेंगे. Then उसके बाद we will be left with the bone tumors and the arthritis and the lower limb, which we will study in the next session. Okay, okay, let's study about CTEV. Earlier और अभी भी यूज होता है टर्म क्लब फुट. व्हाट इज क्लब फुट? फुट की डिफॉर्मिटीज को क्लब करके एक सिंगल नाम दिया गया है, दैट इज क्लब फुट. एंड अमंग क्लब फुट, equinovarus deformity is most common, followed by calcaneo valgus deformity. So most common is the equinovarus deformity, and this is called as CTEV, that is congenital talipes equinovarus. Okay, it what is the incidence? 1 in every 1,000 live births. This is the incidence. Okay, and there are important joints, ligaments that you should remember. Ankle joint किसके बीच में होता है? Tibia and टैलस के बीच में. सब टैलर जॉइंट किसके बीच में होता है? टैलस एंड कैल्केनियम के बीच में. एंड कैल्केनियम आर्टिकुलेट्स विद सी टू सी क्यूबॉइड एंड द टैलस आर्टिकुलेट्स विद नेविकुलर, तो टेलो नेविकुलर जॉइंट. ओके, फोरफुट, मिडफुट, हाइंड फुट, तीन लेवल्स होते हैं दैट यू ऑल नो. हियर यू कैन सी इन द डायग्राम वेरी इजीली. दीज आर दी phalanges, these are the metatarsals, and first metatarsal great toe पे sesamoid bones होती है. Okay, this here, this is your calcaneum. Okay, this is your calcaneum, this is your talus, this is your navicular, this is your cuboid, this is your three cuneiforms, medial, intermediate and the lateral cuneiforms. Okay, here you can also see in the images three cuneiforms, cuboid, calcaneum and navicular and the talus. Here in the lateral you can see this is your calcaneum, this is your talus. Okay, this is your navicular and here are your cuneiforms. Okay, अब three बहुत important ligaments है that you should know. First is the deltoid ligament, also called as the medial collateral ligaments. दो parts में होता है, superficial and deep में होगा. Okay, this is your medial collateral ligament or the deltoid ligament. Second is the interosseous ligament between calcaneum and the talus. Calcaneum and talus के बीच में interosseous ligament. And third one is the spring ligament, and this ligament is between the calcaneum and navicular. It is between the calcaneum and the navicular. This is your spring ligament. Capsular ligaments होंगे. Okay, and plantar ligaments. Okay, now you have tendons. तो सबसे पहले posteriorly you need to remember three tendons: tibialis posterior. Okay, you need to remember three tendons: tibialis posterior, flexor digitorum longus and the flexor hallucis longus. Okay, flexor digitorum longus, flexor hallucis longus and the tibialis posterior. And tibialis posterior is the most important muscle related to the pathology of the फ्लैट फुट. और टिबियल, और यहाँ पे आपको क्या मिलेगा? पोस्टीरियर टिबियल आर्टरी एंड नर्व भी मिलेगा. इट इज यूजफुल इन पीएमएसटीआर ऑपरेशंस जो अपन देखेंगे. नाउ नोमेनक्लेचर. तो फर्स्ट ऑफ ऑल इक्वाइनस अगर टो पे चले हॉर्स के जैसे, इट इज इक्वाइनस. कैल्केनियम और कैल्केनियम पे चले ऐसे, इट इज कैल्केनियस. वेरस एंड वेलगस, वेलगस में एल आता है यानी वो लेटरल होगा. वेरस इज इन्वर्टेड एंड अडक्टेड एट द मिड टार्सल जॉइंट. दिस योर मिड, तो इट विल बी इन्वर्टेड एंड अडक्टेड एट द मिड टार्सल जॉइंट. सो सोल विल फेस इनवर्ड्स. नाउ व्हाट इज कैवस एंड प्लानस? कैवस में जो मीडियल लॉन्गिट्यूडनल आर्च होता है, दैट इज exaggerated, so it will be like this. So this is called as the cavus. Planus में medial longitudinal arch is flattened, and in splay the transverse arch is flattened. Okay, here you can see this is equinus. Okay, here this is your varus, this is your clubfoot. Okay, cavus, here you can see लॉन्गिट्यूड मीडियल साइड में प्रोमिनेंट क्रीज बन जाती है कैवस के अंदर, बिकॉज देयर इज एक्सैजरेशन ऑफ द मीडियल लॉन्गिट्यूडनल आर्च. हियर इज द अडक्शन, द वेरस. ओके, and the equinus. This is your splay where the transverse arch is flattened. Here are your different things. Okay, very easy. Now you can आंसर सच क्वेश्चंस वेरी इजीली. बस आपको पता होना चाहिए कि किस वर्ड का क्या मतलब है. ओके, इटियोलॉजी. मोस्ट कॉमनली CTEV is idiopathic in origin. Most commonly it is idiopathic in origin, but it is called as the primary CTEV and it is generally congenital. But in secondary CTEV क्या होता है? There is some cause या there is some other disease related to the CTEV, and the most common is the AMC, that is arthrogryposis multiplex congenita, where the other joints will be involved. Okay, the other joints will be involved. नाउ सेकेंडरी क्लब फुट जो होता है उसमें एक स्पाइना बाइफिडा मत भूलना कभी. ओके, स्पाइना बाइफिडा अदर पैरालिसिस डिसऑर्डर्स के साथ एसोसिएटेड होगा, तो स्पाइना बाइफिडा इज वेरी इंपॉर्टेंट. अदर आप पोलियो माइलोडिस्प्लेजिया फ्रेडरिक्स एट्रेक्सिया एक्सेट्रा. तो फर्स्ट तो पैरालिटिक डिसऑर्डर्स, न्यूरोमस्कुलर डिसऑर्डर्स, एंड सेकेंड इज AMC. ओके, नाउ पैथोएनाटमी में क्या होगा? बोन्स आर जनरली स्मॉलर and the neck of the talus will be angulated downwards and medially. ध्यान रखना, posterior tibialis posterior muscle सबसे important है among muscles, and among bones talus is most important in club foot. Okay, calcaneum will be small and it concave side में it medial side में it will be concave. Okay, now inversion कौन सा कहाँ पे होता है? जो inversion deformity होती है it is at the subtalar joint, whereas the adduction and the cavus deformity is at the mid tarsal joint. ओके, रिमेंबर. तो मसल्स एंड टेंडन्स, पोस्टीरियरली सबसे पहले टेंडो एक्लीज आएगा, देन 3 मसल्स टिबियालिस पोस्टीरियर, FDL एंड FHL, एंड 3 कैप्सूल्स आएंगे, पोस्टीरियर कैप्सूल ऑफ एंकल, सबटेलर जॉइंट्स, एंड medially 3 ligaments आएंगे, वेरी इंपॉर्टेंट, दैट वी हैव डिस्कस्ड. 3 ligaments, टेलोनेविकुलर, deltoid ligament, and the spring ligament. Deltoid ligament, talus and calcaneum, deltoid ligament is medial collateral ligament. Okay, spring ligament between calcaneum and navicular, and talus and navicular के बीच में will be talonavicular ligament. Okay, now skin में क्या होगी? There will be shortening in the medial side, so there will be deep crease on the medial side. We have seen already, here you can see deep crease on the medial side, mainly due to the cavus. There will be dimpling on the lateral side. Okay, and when the child will start walking on this deformed foot, it will get rigid and it is very difficult to treat. And on the bony prominences on the lateral side there will be callosities and the bursa. Okay, so here you can see the heel will be small but the fat will be more. Okay, fat बहुत ज़्यादा होता है प्राइमरी के अंदर, and high deep creases, and the calf will be abnormally thin. Okay, the calf will be abnormally thin. And remember, mostly the cases can be detected at the time of birth if there is proper communication, proper training given to the ANMs or the LHVs or the nurses that do the delivery at the periphery. Okay, so it can be detected at birth and it has the most favorable outcome, and just by proper manipulation only mostly it can get cured. There is even no need of casting, etc. So this is called as the postural equinovarus. And how do you treat it? First day of the life set the treatment starts. And how you explain it to the mother कि जब भी mother is going for the feed, okay, he will fix the foot in the normal anatomical position, जो आप उसको एक बार समझा दोगे, and by putting her thumb over the head of the talus. Okay, and you have to do it for 5 minutes every day with 50 seconds के session, and the pressure should be like that the fingers of the mother get blenched. नाउ ड्यूरिंग इन्फेंसी अगर आपने 1 साल के अंदर अंदर ही डिटेक्ट कर लिया है तो उसके भी यू हैव गुड रिजल्ट्स, बट लेट इन्फेंसी, अर्ली चाइल्डहुड और लेट चाइल्डहुड में इफ यू हैव डिटेक्टेड, they have a poor prognosis and generally surgery is required. So pathological changes आपके क्या क्या होंगे CTEV के अंदर, club foot के अंदर? deep crease, dimples on the lateral side, shortening of the medial side of callosities and bursas of the lateral side. We have discussed this. Okay, now examination में क्या होगा? जनरली इन नॉर्मल न्यूबॉर्न चाइल्ड क्या होता है? नॉर्मल न्यूबॉर्न चाइल्ड you can dorsiflex the foot very easily and such that the fingers or the toe tips will touch the shin. Okay, this is a very good screening test in the initial and mild variety of the club foot, which is not possible in the club foot. 60% केसेस में ये bilateral होता है, and unilateral में the affected limb will be smaller. In unilateral में the affected foot will be smaller. Okay, so the foot is equinus, varus and adduction. Heel small, deep prominence, and the outer side of the foot is gently convex. Okay, remember this. Now general examination में if it is due to some secondary CTEV, so there will be symptoms or deformities related to the neurovascular complications. If it is spina bifida, polio, or if there is AMC, the other joints can be there. Now there is another terminologies involved with the CTEV and you should know this. What is relapsed? Relapsed अगर एक बार ठीक होके वापस हो गया है. नेग्लेक्टेड, डायग्नोसिस होने के बाद भी 1 year तक it is not treated, it is neglected. Resistant, if the foot deformities are not responding to the manipulation and POP casting. Rigid, if it is not corrected and bony deformities हो गई है. And what is supple? Supple is if foot is deformed but can easily be brought back to the normal position, it is called as supple. Okay, उसको क्या बोलते हैं? It is called as supple. Now it is very important, that is the differentiating features between primary and the secondary clubfoot. Important. Presence is birth. The affected side में bilateral is more common. Foot size is smaller. Heel is also smaller with more amount of fat. यहाँ पे ये सब normal होगा. And skin chubby होगी, but इसमें atrophy होगी. Creases will be absent. Neurological examination will be normal here, not normal here. And prognosis is good for primary CTEV or primary club foot, and it is poor for the secondary club foot. Okay, now एक टेलोकैल्केनियल एंगल होता है which is also called as the kites angle. And just आपको इतना याद रखना है, kites angle is the टेलोकैल्केनियल angle and it is normally more than 35 degrees, but in CTV this angle is decreased. This angle is decreased, just remember it to sir. Okay, now treatment के लिए non-operative treatments are the treatment of choice, where you manipulate and then you do the casting and then you do the serial casting like every week. So there are two methods of manipulation and POP casting. First is the kites method and second is the Ponseti method, and we use Ponseti method in our clinical practice में we use the Ponseti method. Remember this. And manipulation alone भी कर सकते हैं जहाँ पे POP casting की जरूरत भी नहीं है, and it is done in newborn by the mother, as I have told you. Okay, as I have told you. Now firstly we'll study about the Ponseti philosophy. तो Ponseti philosophy के लिए firstly, according to Ponseti, the calcaneo-cuboid navicular complex is internally rotated or abducted under the plantar flexed talus. Okay, so primary deformity is in the talus and it is plantar flexed, and due to which there is इंटरनल रोटेशन और अडक्शन ऑफ दिस कॉम्प्लेक्स, ये इंपॉर्टेंट है, याद रखना है, ठीक है। इसके बाद remember, all the deformities are not corrected at once. Okay, firstly you treat the cavus deformity, then your varus or adduction or internal rotation, then at last you treat this equinus deformity. ओके, वेरी इंपॉर्टेंट, ठीक है। नाउ इसमें आप जब मैनिपुलेशन करते हो, द मैनिपुलेशन इज डन बाय कीपिंग योर थंब प्रेशर ओवर द टेलस हेड, okay, whereas in kites the pressure is over the calcaneocuboid joint. Treatment is started as early as possible in the first week of life, and after every 7 days of 1 week you do the casting, and the casting is the above knee cast. Okay, above knee cast you put with knee in flexion, to relax that tendo Achilles, you do above knee casting. Okay, very important. एंड इक्वाइनस डिफॉर्मिटी को आप कैसे ट्रीट करते हो? इट इज ट्रीटेड नॉट बाय पीओपी, बाय अ स्मॉल सर्जरी एट द एंड ऑफ द ट्रीटमेंट कॉल्ड एज टिनोटमी, और इसमें आप टेंडो एक्लीज को काट देते हो एंड यू लीव एज सच, और वो वापस क्या हो जाती है, it regenerates spontaneously. So tenotomy of tendo Achilles is done to correct the equinus. Okay, so this is Ponseti technique. Now the kites phenomena में जो differentiation है वो क्या है, ये 1 month of age पे होगा जबकि वो 1 week पे था, है ना। एंड फर्स्टली द अडक्शन इज करेक्टेड, देन इन्वर्जन एंड देन इक्वाइनस, बट देयर कैवस इज करेक्टेड एवरी वीक की जगह एवरी 2 weeks, एंड यू ओवर करेक्ट, ये ध्यान रखना, काइट्स एंड पॉन्सिटी दोनों के अंदर you over correct the deformity. वहां पे above knee casts were applied, here the below knee casts are applied, and by this method only 30% cases का correction is achieved, whereas by Ponseti the correction is more than 70% तक का correction कर सकते हो. Now for operative methods के लिए if till 3 years और POP casting काम नहीं करी, they have failed, or it is a neglected case, then you go for the operative studies, and that is called as the PMSTR, that is posterior medial soft tissue release, यानी posterior medial side पे you release the soft tissues. Okay, and what are these tissues? We have already discussed. Posterior side में you will cut the tendo Achilles and do its lengthening by the Z plasty. Posterior capsules of the subtalar and the ankle joint, and posterior talofibular calcaneofibular ligaments, 3 tendons, that is tibialis posterior, flexor digitorum longus, flexor hallucis longus, and 3 ligaments, that is talonavicular, deltoid and the spring ligament. अब आपसे क्वेश्चन आ जाए कि डेल्टॉइड में भी कौन सा पार्ट, विच इज हाईली अनलाइकली, इट इज योर सुपरफिशियल पार्ट. ओके, सो अगर CTEV है और सिवियर केस है तो ये सब करते हैं, बट यू एंड ऑन प्लांटर साइड, यस, प्लांटर फेशिया इज ऑल्सो रिलीज, बट इफ यू हैव टू do the only correction of equinus, then you have to go for the limited soft tissue release, और equinus, सिर्फ equinus करेक्ट करने के लिए posterior release करेंगे, adduction ठीक करने के लिए medial release करेंगे, and cavus के लिए only plantar release is done. Okay, so this is very important, याद रखना है आपको, ठीक है. नाउ टेंडन ट्रांसफर भी कर सकते हो, जस्ट रिमेंबर किस किस का, टिबियालिस एंटीरियर और टिबियालिस पोस्टीरियर का, एंड देयर आर डिफरेंट टाइप्स ऑफ ऑस्टियोटमी that can be done to treat the neglected or the rigid cases, and इनके नाम याद रख लो. The name is Devier's osteotomy and the Dilvian Evan procedure. Okay, and wedge tarsectomy or the triple arthrodesis. Wedge tarsectomy 8 to 11 years of the age में करते हैं, and more than 11 or 12 years में you go for the triple arthrodesis. Remember the age group, it is very important. Okay, age group बहुत important है. And what is arthrodesis? सब joints का fusion कर देना. कौन से? कैलस, कैल्केनियम एंड नेविकुलर क्यूबॉइड, ये जो जॉइंट्स होते हैं ट्रिपल आर्थ्रोडेसिस, टेलोकैल्केनियन, calcaneonavicular and the calcaneocuboid joint. It is triple arthrodesis above 12 years, and 8 to 12 years में you go for the wedge tarsectomy. Remember this. Okay, Elizaro technique भी you can use. एंड मैं अब ये ठीक हो गया. ओके, बट इसको ठीक करने के बाद यू हैव टू मेंटेन दिस करेक्शन. आफ्टर this you have to maintain the correction, and for maintenance of the correction you have CTEV splints, Dennis Brown splint and the CTEV shoes. So CTEV shoes की characteristic you should know, and these are put when child starts walking. एक बार बच्चे ने चलना शुरू कर दिया है उसके बाद you use these CTEV shoes. And what are the modifications? सबसे पहले there will be no heel, the inner border will be straight. Okay, the inner border will be straight, not curved like this, it will be straight, and the outer shoe will be raised. आउटर शू बॉर्डर जो होगी वो रेज्ड होगी ताकि इन्वर्जन नहीं हो पाए. एंड देयर विल बी नो हील, एंड 5 year old age तक you have to wear it. And if the child has not started walking, then you go for the Dennis Brown splint. Okay, and walking start करने के बाद दिन में जब वो चलता है तब CTV shoes, and रात में Dennis Brown splint. Okay, now plan of treatment. Resistant club feet hai, so you have to evaluate if there is any secondary cause. Okay, of the club foot, you have to evaluate for the AMC. Recurrent or the neglected cases may you have to go for the surgery. You have to go for the surgery. Okay, so I guess आज के लिए इतना काफी है. We have taken more than 3 hours of marathon session. Okay, so next we will continue this marathon session tomorrow, that is on Monday at 6 September. We'll have the second part of this marathon session of again 3 to 3.5 hours, and where we'll discuss the pediatric orthopedics like CDH, etc. We'll discuss the entire lower limb orthopedics. Okay, and we'll discuss the bone tumors and the arthritis. My least priority will be the bone tumors and arthritis, because I have already discussed them with you in the रैपिड रिवीजन कोर्सेज. तो सबसे पहले अपन पीडियाट्रिक ऑर्थोपेडिक्स एंड लोअर लिम्ब पढ़ेंगे, फिर उसके बाद अगर टाइम मिला तो बोन ट्यूमर्स एंड आर्थराइटिस. ओके, सो आई होप यू लाइक द वीडियो. Please do attend tomorrow's lecture. For this you just have to download the Unacademy app and subscribe using this code, both of which are absolutely free. Okay, so please join me on the marathon session part 2 tomorrow on the Unacademy app. So I hope you like the video. If you like the video, please like, share and subscribe. And you can subscribe for any course on the Unacademy, be it NEET, UG, PG, UPSC, CAT, NET, बोर्ड एग्जामिनेशंस एक्सेट्रा हम सब पढ़ाते हैं और सब पे मेरा कोड भी चलता है. ओके, सो ऑल द बेस्ट. स्टडी जितना मन हो, stay positive, eat healthy, sleep and think positive. Think कि only 7 days left. Next Sunday को इस time पे I will be free and I will be doing party. Okay, so think like that, because I used to think like that. Okay, so I am tired now. 3 घंटे से लगातार बोल रहा हूँ. इट्स फॉर द फर्स्ट टाइम इन माई लाइफ कि मैं लगातार 3 घंटे से ज़्यादा बोला हूँ. सो यस, सी यू टुमारो. बाय, गुड नाइट.